Hi there, preparing for D455. OA exam can feel overwhelming, but it doesn't have to be. Stick with us and we're going to help you with it. We built a free question bank for the D455 OA exam. Preparing for an OA is no joke, so our guides and practice questions are completely free. In this video, we will cover questions from medication safety, endocrine emergencies, electrolyte imbalances, acute care, professional ethics. So, let's get started.
1. A nurse is preparing to give a scheduled medication to a hospitalized client who is recently transferred from another unit and is now sleeping in an unfamiliar room. Which action best ensures the nurse follows the gold standard for safe client identification before administration? A. Confirm the assigned room number. B. Ask a nearby family member. C. Check the client identification armband. D. Verify the name on whiteboard. What do you think is the answer? Correct answer, C. Check the client identification armband. Explanation. Option C is correct because the identification armband is the gold standard for verifying client identity. The nurse must check the armband and use at least 2 identifiers before administering any medication to ensure safety. Option A is incorrect because room numbers are never acceptable patient identifiers. Clients frequently move between rooms, and relying on location alone risks giving medication to the wrong person entirely. Option B is incorrect because family members may provide inaccurate information due to stress or confusion. The nurse must independently verify identity using approved identifiers rather than relying on second-hand verbal confirmation. Option D is incorrect because whiteboards can contain errors and may not be updated after room transfers. They are supplemental communication tools and are not considered reliable, approved client identifiers. All right, let's tackle a concept that shows up constantly on nursing exams. Safe client identification. The question here is about what the nurse should do before giving a medication to a sleeping client who just transferred rooms. The gold standard, and this is non-negotiable, is checking the client's identification armband. That armband is physically attached to the client. It doesn't change when they switch rooms, it doesn't rely on someone else's memory, and it doesn't get erased or written over like a whiteboard might. Room numbers are never acceptable identifiers. Clients move around. A family member might be stressed or confused and give you bad information. A whiteboard could be outdated, especially right after a transfer. The armband plus asking the client to state their name and date of birth, that's your 2 identifier minimum. Here's a WGU D455 exam tip for you. When you see a question about verifying client identity, the answer almost always involves the identification armband. That's your anchor, quick recall hook. Think. Armband =, attached to the patient. =, always reliable. 2. After administering an opioid analgesic, such as hydromorphine, to a post-operative client, the nurse plans a reassessment. Which combination of assessments should the nurse prioritise within 30 minutes of giving this medication to evaluate both therapeutic response and potential adverse reactions? A. Respiratory rate and pain level. B. Bowel sounds and skin turgor. C. Urinary output and appetite level. D. Wound drainage and temperature reading. Can you guess the answer? Correct answer, A. Respiratory rate and pain level. Explanation. Option A is correct because opioids can cause respiratory depression, making respiratory rate essential to monitor. Pain level reassessment determines if the medication achieved its therapeutic goal within the expected time frame. Option B is incorrect because bowel sounds and skin turgor are important general assessments, but are not the priority within 30 minutes of opioid administration when respiratory depression is the primary concern. Option C is incorrect because urinary output and appetite are longer-term monitoring parameters. They do not address the immediate risk of respiratory depression or confirm short-term pain relief effectiveness. Option D is incorrect because wound drainage and temperature relate to surgical site monitoring rather than opioid-specific effects. These do not evaluate the drug's therapeutic response or most dangerous adverse reaction. This one is about what to check after giving an opioid like hydromorphone. You gave the drug. Now what do you watch for in the next 30 minutes? Two things matter most: respiratory rate and pain level. Respiratory depression is the big danger with opioids. The drug suppresses the brainstem's respiratory center, so breathing can slow down to dangerous levels. That's your adverse reaction check. Pain level tells you if the drug actually worked. That's your therapeutic response check. Bowel sounds, skin turgor, urine output, appetite. Sure, those matter over time, but they're not what you're hunting for at the 30-minute mark. Wound drainage and temperature are about the surgical site, not the opioid. Here's a WGU D455 exam tip for you. When a question asks about reassessment after an opioid, pair the most dangerous side effect with the therapeutic goal. That's respiratory rate plus pain level every time. Quick recall hook: opioid follow-up equals sign, breathing plus pain. 3. A client in the post-anesthesia care unit presents with a respiratory rate of 8 breaths per minute, heart rate of 62, and oxygen saturation of 94% following surgery. The nurse recognises these findings as consistent with opioid-induced respiratory depression. Which intervention takes highest priority? A. Reposition the client to side lying. B. Increase the oxygen flow rate immediately. C. Notify the surgeon of vital signs. D. Administer naloxone as prescribed. What do you think is the answer? Correct answer: D. Administer naloxone as prescribed. Explanation. Option D is correct because naloxone is the specific opioid antagonist that reverses respiratory depression by blocking opioid receptor sites. Administering it promptly addresses the life-threatening suppression of the respiratory drive. Option A is incorrect because repositioning alone does not reverse the pharmacological cause of opioid-induced respiratory depression. While positioning may support ascend airway patency, it cannot counteract the drug effect on the brainstem. Option B is incorrect because increasing oxygen treats the symptom of low saturation, but does not address the underlying cause. The client needs reversal of opioid effects to restore adequate spontaneous breathing. Option C is incorrect because notifying the surgeon is appropriate, but not the highest priority when the client has dangerously slow respirations. The nurse must intervene immediately to reverse the respiratory depression first. Here's a post-anesthesia scenario where the client's respiratory rate is 8, heart rate is 62, and oxygen saturation is 94%. That respiratory rate of 8 is the red flag. It's way below normal. The nurse recognises this as opioid-induced respiratory depression. So what's the priority? Naloxone. Naloxone is the specific opioid antagonist. It works by competing for and blocking opioid receptor sites in the brain, which directly reverses the respiratory depression. Repositioning the client to side lying might help keep the airway open, but it doesn't fix the pharmacological problem. The opioid is still sitting on those receptors, suppressing the drive to breathe. Increasing oxygen flow treats the low saturation number, but it's a band-aid. You're not fixing the cause. Notifying the surgeon matters, but not before you act on a respiratory rate of 8. That client needs naloxone now, not a phone call. Here's a WGU D455 exam tip for you. When you see respiratory depression plus recent opioid use, the answer is naloxone. Don't get distracted by supportive measures. Go straight to the reversal agent. Quick recall hook: naloxone equals sign Narcan equals sign knocks opioids off receptors. 4. A nurse administers clonazepam to a client diagnosed with acute stress disorder. Shortly after administration, the client requests to use the restroom. Considering the known effects of benzodiazepines on the central nervous system, Which nursing action best demonstrates safe medication management in this situation? A. Instruct the client to ambulate independently. B. Assist the client to the bathroom. C. Administer an opioid agonist for reversal. D. Monitor serum calcium levels immediately. Do you know the answer? Correct answer. B. Assist the client to the bathroom. Explanation. Option B is correct because benzodiazepines cause sedation and impaired coordination, significantly increasing full risk. Assisting the client to the bathroom directly addresses the safety concern created by the medication's central nervous system effects. Option A is incorrect because encouraging independent ambulation after benzodiazepine administration ignores the sedation and impaired coordination caused by the drug, placing the client at significant risk for falls and injury. Option C is incorrect because opioid agonists are not appropriate reversal agents for benzodiazepines. The specific benzodiazepine antagonist is flumazenil, which would only be used if dangerous oversedation or respiratory depression occurred. Option D is incorrect because calcium monitoring is not indicated for benzodiazepine therapy. Benzodiazepines enhance gamma-aminobutyric acid activity in the brain and do not have a clinically significant direct effect on calcium levels. A client with acute stress disorder just got clonazepam. That's a benzodiazepine. And now they want to use the restroom. What's the safe move here? Assist the client to the bathroom. Benzodiazepines work by boosting GABA activity in the brain, which produces sedation, muscle relaxation, and impaired coordination. That combination is a recipe for falls, letting the client walk on their own after a benzo dose is asking for trouble. Now, option C mentions an opioid agonist for reversal. That's completely wrong drug class. The benzodiazepine reversal agent is flumazenil, and you'd only use it for dangerous oversedation or respiratory compromise, not routine bathroom trips, monitoring calcium. That's got nothing to do with benzos. Benzodiazepines don't affect calcium levels in any clinically meaningful way. Here's a WGU D455. Exam tip for you. Anytime a question pairs a CNS depressant with a physical activity like ambulation, think full risk and think assistance. Quick recall hook. Benzo = balance problems = be there to help. 5. During a nebulizer treatment with albuterol, a client develops tremors and a heart rate of 120. The client appears anxious and asks whether the medication is causing harm. Based on the pharmacological profile of short-acting beta-2 agonists, which nursing response is most appropriate? A. Educate that these are expected effects. B. Immediately discontinue the treatment. C. Prepare flumazenil for reversal administration. D. Request an urgent cardiac consultation. Do you know the answer? Correct answer. A. Educate that these are expected effects. Explanation. Option A is correct because tachycardia, tremors, and shakiness are known pharmacological effects of a short-acting beta-2 agonists like albuterol. These represent expected side effects rather than dangerous adverse reactions requiring treatment discontinuation. Option B is incorrect because stopping the bronchodilator treatment for expected side effects denies the client necessary respiratory therapy. Tachycardia and tremors are common albuterol effects that typically resolve after treatment completion. Option C is incorrect because flumazenil is the reversal agent for benzodiazepines, not bronchodilators. There is no specific reversal agent indicated for the expected pharmacological side effects of albuterol treatment. Option D is incorrect because requesting a cardiac consultation for albuterol-induced tachycardia is an overreaction to an expected pharmacological response. The elevated heart rate results from beta receptor stimulation and is not a cardiac emergency. A client on an albuterol nebulizer treatment develops tremors and a heart rate of 120. They're scared. Is this harmful? No. Educate them that these are expected pharmacological effects. Albuterol is a short-acting beta-2 agonist. Its job is to relax bronchial smooth muscle. But beta receptors aren't only in the lungs. They're in the heart and skeletal muscles too. So when you stimulate beta receptors, you get bronchodilation. That's what you want. Plus tachycardia and tremors, which are predictable side effects. You don't stop the treatment for expected effects. The client needs this medication to breathe. Flumazenil reverses benzodiazepines, not bronchodilators. That option makes no pharmacological sense. And ordering a cardiac consult for drug-induced tachycardia at 120? That's an overreaction. The heart rate will come down after the treatment ends. Here's a WGU D455. Exam tip for you. When you see albuterol plus tremors plus tachycardia in a question, the answer is always educate, not discontinue. Quick recall hook. Albuterol equals sign all beta receptors get stimulated, equals sign tremors and fast heart are normal. 6. A nurse is providing discharge education to a client who has been prescribed dabigatran for atrial fibrillation. The client asks whether any dietary restrictions or routine blood monitoring will be necessary while taking this new medication. Which response by the nurse demonstrates accurate pharmacological knowledge? A. Limit vitamin K intake in foods. B. Monitor the INR level weekly. C. Avoid all green leafy vegetables. D. Avoid non-steroidal anti-inflammatory drugs. Can you guess the answer? Correct answer. D. Avoid non-steroidal anti-inflammatory drugs. Explanation. Option D is correct because concurrent use of non-steroidal anti-inflammatory drugs with dabigatran significantly increases bleeding risk. Unlike warfarin, dabigatran does not require INR monitoring or dietary vitamin K restrictions for therapeutic management. Option A is incorrect because limiting vitamin K intake is a teaching point specific to warfarin therapy. Dabigatran is a direct thrombin inhibitor, and its mechanism of action is not affected by dietary vitamin K consumption. Option B is incorrect because routine INR monitoring is required for warfarin, not dabigatran. Direct thrombin inhibitors work through a different mechanism that does not require regular coagulation laboratory monitoring for dose adjustments. Option C is incorrect because avoiding all green leafy vegetables is an overly restrictive dietary modification associated with warfarin. Dabigatran does not interact with vitamin K, so these nutritious vegetables do not need elimination. A client going home on dabigatran for atrial fibrillation wants to know about diet restrictions and blood monitoring. Here's the thing that trips students up. Dabigatran is not warfarin. Warfarin is the drug where you worry about vitamin K foods and check INR levels weekly. Dabigatran is a direct thrombin inhibitor. It works by a completely different mechanism. No INR monitoring needed. No vitamin K dietary restrictions. So what do you teach? Avoid NSAIDs. Non-steroidal anti-inflammatory drugs combined with dabigatran significantly jack up bleeding risk. Both drugs affect hemostasis through different pathways, and together they compound the danger. Limiting vitamin K. That's warfarin territory. Monitoring INR weekly. Warfarin again. Avoiding all green leafy vegetables. Also warfarin. And even then it's about consistency rather than elimination. Here's a WGU D455 exam tip for you. When you see dabigatran in a question, mentally cross off anything related to vitamin K or INR. Those belong to warfarin. The correct teaching point for dabigatran is NSAID avoidance, quick recall hook. Dabigatran equals sign direct thrombin equals sign ditch the NSAIDs. 7. A client receiving eptifibatide for acute coronary syndrome is being closely monitored in the cardiac unit. The nurse assesses several clinical findings during routine rounds. Which single finding places the client at the greatest immediate risk and requires the most urgent nursing intervention? A. Blood detected in the urine. B. unresponsive to painful stimuli. C. Blood pressure slightly below baseline. D. Small bruise on the forearm. What do you think is the answer? Correct answer, B. Unresponsive to painful stimuli. Explanation. Option B is correct because unresponsiveness to painful stimuli in a client receiving eptifibatide indicates potential intracranial hemorrhage. This is the most immediately life-threatening bleeding complication requiring emergency intervention and rapid neurological evaluation. Option A is incorrect because blood in the urine indicates a bleeding complication that requires monitoring and reporting, but it is not as immediately life-threatening as altered consciousness suggesting intracranial hemorrhage. Option C is incorrect because a slight decrease in blood pressure from baseline may reflect the medication effect or mild fluid shifts. It does not carry the same emergency status as complete unresponsiveness to stimuli. Option D is incorrect because a small bruise on the forearm is an expected minor bleeding manifestation during anticoagulant therapy. It does not indicate a serious hemorrhagic event requiring urgent intervention. A client on eptifibatide, that's a glycoprotein laboratory inhibitor used in acute coronary syndrome, and the nurse finds several things on assessment: blood in the urine, slight blood pressure drop, small forearm bruise, and unresponsiveness to painful stimuli. Which one is the emergency? Unresponsiveness to painful stimuli. Here's why. Eptifibatide inhibits platelet aggregation, which means the client is at high risk for bleeding anywhere, but not all bleeding is equally dangerous. A bruise on the forearm. Expected minor bleeding. Blood in the urine. Concerning needs monitoring, but the client is conscious and stable. Slight blood pressure drop. Could be many things, but when a client on a potent antiplatelet drug becomes completely unresponsive to pain, that's a red flag for intracranial hemorrhage. Bleeding inside the skull is the most immediately lethal bleeding complication because it causes rapid neurological deterioration and brain herniation. Here's a WGU D455. Exam tip for you. With anticoagulant and antiplatelet drugs, always rank bleeding complications by location. Brain bleeds top the list. Quick recall hook. Unresponsive on antiplatelets equal sign brain bleed until proven otherwise. 8. A hospitalized client has laboratory results showing a platelet count of 20,000, which is critically below the normal range. The nurse is reviewing the medication administration record and planning care for the shift. Which nursing action is most important to protect this client from harm? A. Avoid giving intramuscular injections. B. Encourage vigorous oral hygiene measures. C. Apply ice packs to all extremities. D. Administer aspirin for mild headache. What do you think is the answer? Correct answer, A. Avoid giving intramuscular injections. Explanation. Option A is correct because a critically low platelet count creates extreme risk for uncontrolled bleeding. Intramuscular injections penetrate deep muscle tissue where hemorrhage is difficult to detect and control through external measures. Option B is incorrect because vigorous oral hygiene with hard bristled brushes can cause gum bleeding in a severely thrombocytopenic client. Gentle oral care with soft swabs is recommended to prevent mucosal injury. Option C is incorrect because applying ice packs to all extremities is not a standard intervention for thrombocytopenia. While cold therapy may reduce minor localized bleeding, it does not address the systemic risk of hemorrhage. Option D is incorrect because aspirin inhibits platelet aggregation and would further impair the already critically low platelet function. Administering aspirin to this client would dangerously increase the existing bleeding risk. The client's platelet count is 20,000. Normal is 150,000 to 400,000. This is critically low. Severe thrombocytopenia. What's the most important thing to protect this client from? Avoid intramuscular injections. IM injections go deep into muscle tissue. If a client with almost no platelets starts bleeding into the muscle, you can't see it, and you can't apply pressure to stop it. The hemorrhage just spreads through the tissue. Now look at the wrong options. Vigorous oral hygiene with hard bristled brushes will tear up the gums and cause bleeding. You'd use soft swabs instead. Ice packs on all extremities. That's not a standard thrombocytopenia intervention. And aspirin inhibits what little platelet function is left. Giving aspirin to this client would be genuinely dangerous. Here's a WGU D455 exam tip for you. When you see a critically low platelet count, think bleeding precautions. Avoid IM injections, use soft oral care, avoid aspirin and other antiplatelet agents. Quick recall hook. Low platelets equal sign, low punctures. No needles deep in muscle. 9. A client taking dabigatran presents to the emergency department with signs of a serious hemorrhagic event. The emergency team is preparing for intervention while the nurse gathers critical medication history. Which information is most important for the nurse to communicate to the treatment team? A. The client's last INR result. B. Whether the client takes vitamin K. C. That idarucizumab is the specific antidote. D. The brand name of the medication. Do you know the answer? Correct answer, C. That idarucizumab is the specific antidote. Explanation, option C is correct because idarucizumab is the specific reversal agent for dabigatran in emergency hemorrhage situations. Communicating this information ensures the treatment team can rapidly obtain and administer the appropriate antidote. Option A is incorrect because INR monitoring is not used for dabigatran therapy. Dabigatran is a direct thrombin inhibitor, and its anticoagulant effect is not accurately reflected by INR values used for warfarin management. Option B is incorrect because vitamin K is the reversal strategy for warfarin, not dabigatran. Dabigatran works through a direct thrombin inhibition, and vitamin K administration would have no therapeutic effect on reversing its action. Option D is incorrect because while medication identification is helpful, knowing the specific reversal agent is far more clinically urgent during an active hemorrhagic emergency. The antidote information directly guides life-saving treatment decisions. A client on dabigatran shows up to the ED hemorrhaging. The treatment team is scrambling. What's the most critical piece of information the nurse can give them? That idarucizumab is the specific antidote for dabigatran. In a hemorrhagic emergency, knowing the exact reversal agent saves time and saves lives. The team can immediately request it from pharmacy instead of guessing or trying strategies that won't work. INR results? Useless here. Dabigatran doesn't affect INR the way warfarin does. Vitamin K, that reverses warfarin, not dabigatran. The brand name is nice to know, but it doesn't change treatment decisions the way knowing the antidote does. Here's a WGU D455 exam tip for you. Know your reversal agent pairs cold. Dabigatran gets idarucizumab, warfarin gets vitamin K, heparin gets protamine sulfate. These show up repeatedly. Quick recall hook, dabigatran reversal equal sign idarucizumab. Both start with D. 10. A nurse is caring for a client who has been receiving heparin therapy for 3 days. The client develops new onset of bleeding from the gums and reports dark tarry stools. The nurse recognises these as signs of a potential complication. Which action should the nurse prioritise first? A. Increase the intravenous fluid rate. B. Administer the next scheduled dose. C. Request a dietary consultation referral. D. Hold heparin and notify the provider. Can you guess the answer? Correct answer, D. Hold heparin and notify the provider. Explanation, option D is correct because gum bleeding and dark tarry stools indicate hemorrhagic complications from heparin therapy. The nurse must immediately withhold the anticoagulant and notify the healthcare provider to prevent worsening hemorrhage. Option A is incorrect because increasing intravenous fluids does not address the active bleeding caused by excessive anticoagulation. The priority is to stop the causative agent before managing supportive measures like fluid replacement. Option B is incorrect because administering the next dose of heparin when the client is showing active signs of bleeding would worsen the hemorrhagic complication and could result in a life-threatening situation. Option C is incorrect because a dietary consultation does not address the acute hemorrhagic complication. While nutrition is important for healing, the immediate priority is stopping the medication causing the active bleeding. A client on heparin for 3 days now has bleeding gums and dark tarry stools. Tarry stools, that's melena, and it means blood is being digested in the GI tract. Combined with gum bleeding, this client is showing clear signs of hemorrhagic complications from heparin. The priority? Hold the heparin and notify the provider. You stop the drug that's causing the problem first. Increasing IV fluids doesn't address the bleeding. It's like mopping the floor while the faucet is still running. Giving the next scheduled heparin dose when the client is actively bleeding, that would make things catastrophically worse. A dietary consult has nothing to do with acute hemorrhage. Here's a WGU D455 exam tip for you. When a question describes active bleeding in a client on anticoagulants, the first action is always to hold the medication. Stop the cause, then manage the consequences. Quick recall hook. Bleeding on anticoagulant =. Hold the drug, call the doc. 11. A client newly diagnosed with type 1 diabetes calls the clinic reporting increased thirst over the past several hours. The nurse recognizes this symptom as an early warning sign of diabetic ketoacidosis. Based on the understanding that DKA results from insulin deficiency, which priority action should the nurse recommend? A. Give a dose of regular insulin. B. Drink electrolyte replacement fluids. C. Measure urine output for 24 hours. D. Increase oral water intake immediately. Can you guess the answer? Correct answer. A. Give a dose of regular insulin. Explanation. Option A is correct because increased thirst signals early DKA from hyperglycemia caused by insulin deficiency. Administering prescribed regular insulin corrects the underlying cause by lowering blood glucose and halting ketone production. Option B is incorrect because drinking electrolyte fluids alone does not address the fundamental insulin deficit driving diabetic ketoacidosis. Without insulin administration, glucose cannot enter cells and ketone production will continue. Option C is incorrect because measuring urine output over 24 hours delays urgently needed treatment. This monitoring approach takes too long when the client needs immediate insulin to prevent DKA progression. Option D is incorrect because increasing oral water intake may provide temporary hydration, but does nothing to correct the metabolic crisis of insulin deficiency. The hyperglycemia and ketone production require insulin intervention. A type 1 diabetic calls the clinic saying they've been really thirsty the past few hours. The nurse recognizes this as an early DKA warning sign. What to do first? Give a dose of regular insulin as prescribed. Here's the logic chain. Type 1 diabetes means no insulin production. Without insulin, glucose piles up in the blood but can't get into cells. The body starts breaking down fat for energy, producing ketones. Increased thirst is one of the earliest signals that blood glucose is climbing toward DKA territory. The fix? Insulin. It's the only thing that addresses the root cause. It lets glucose into cells and shuts down ketone production. Electrolyte drinks don't fix insulin deficiency. Measuring urine output for 24 hours? That's a stalling action when the client needs treatment now. More water helps with dehydration a little, but it doesn't touch the metabolic crisis. Here's a WGU D455 exam tip for you. In type 1 diabetes, when you see signs pointing towards DKA, the answer centers on insulin. Insulin is the only intervention that fixes the underlying problem. Quick recall hook. Type 1 plus thirst =. Think insulin, not fluids. 12. A nurse is evaluating a client with type 2 diabetes to determine if discharge teaching has been effective. The client makes several statements about self-management at home. Which client statement indicates the best understanding of long-term diabetes management and complication prevention strategies? A. Blood sugar testing every 4 hours daily. B. Keeping carbohydrate intake below 35%. C. Getting annual eye exams with ophthalmologist. D. Inspecting feet once every month carefully. What do you think is the answer? Correct answer, C. Getting annual eye exams with ophthalmologist. Explanation: option C is correct because diabetic retinopathy is a leading cause of blindness, and annual ophthalmological screening enables early detection and treatment. This statement demonstrates correct understanding of essential preventive diabetes care. Option A is incorrect because blood sugar monitoring frequency depends on the individualized treatment plan rather than a rigid every 4 hour schedule. This statement reflects a misunderstanding of personalized diabetes self-management principles. Option B is incorrect because the recommended carbohydrate intake for diabetes management is 45 to 65% of total calories. Restricting to 35% is unnecessarily low and nutritionally inappropriate. Option D is incorrect because foot inspection should occur daily, not monthly. Diabetic neuropathy reduces sensation, making daily visual inspection critical for detecting wounds, infections, or skin breakdown before complications develop. The nurse is checking whether discharge teaching stuck for a type 2 diabetic. The client makes several statements, and you need to pick the one that shows correct understanding. The winner is getting annual eye exams with an ophthalmologist. Diabetic retinopathy is a leading cause of blindness, and it develops silently. By the time you notice vision changes, significant damage is already done. Annual screening catches it early enough to treat. Blood sugar every 4 hours? That's too rigid. Monitoring frequency depends on the individual treatment plan. Someone on oral meds alone might check once daily, while someone on insulin might check more often. Keeping carbs below 35% of total calories? Too low. The recommended range is 45 to 65%. And inspecting feet monthly? Way too infrequent. Diabetic neuropathy numbs the feet, so daily visual inspection is the standard because you might not feel a wound forming. Here's a WGU D455 exam tip for you. When a question asks which client statement shows correct understanding, eliminate the ones with wrong numbers or wrong time intervals first. Quick recall hook. Diabetes eyes = yearly, feet = daily. 13. A client with type 2 diabetes who regularly takes metformin is admitted to the hospital with acute heart failure and significant shortness of breath. The admitting nurse reviews the home medication list and identifies a critical safety concern. Which nursing action regarding metformin is most appropriate? A. Continue metformin with increased monitoring. B. Withhold metformin and notify the provider. C. Administer metformin with a full meal. D. Crush the metformin for easier swallowing. What do you think is the answer? Correct answer, B. Withhold metformin and notify the provider. Explanation: option B is correct because metformin must be withheld during acute heart failure. Compromised tissue perfusion dramatically increases the risk of lactic acidosis, a potentially fatal metabolic complication associated with metformin use. Option A is incorrect because continuing metformin with increased monitoring does not eliminate the dangerous risk of lactic acidosis. When tissue perfusion is compromised in acute heart failure, even monitored metformin use is unsafe. Option C is incorrect because administering metformin with food reduces gastrointestinal side effects during normal use, but does not address the critical contraindication. Acute heart failure with poor perfusion makes any metformin dose dangerous. Option D is incorrect because the formulation of the medication is irrelevant when there is a clinical contraindication. Crushing metformin for easier administration does not resolve the lactic acidosis risk from compromised perfusion. A type 2 diabetic on metformin gets admitted with acute heart failure and serious shortness of breath. The nurse reviews the med list and spots a problem. The correct action is to withhold metformin and notify the provider. Metformin's big scary side effect is lactic acidosis, and the risk goes through the roof when tissue perfusion is compromised, which is exactly what happens in acute heart failure. The heart isn't pumping well enough, tissues aren't getting adequate blood flow, and metformin's metabolism depends on good perfusion. Continuing it with increased monitoring doesn't cut it. Monitoring won't prevent lactic acidosis, it'll just let you watch it happen. Giving it with food reduces GI side effects during normal times, but food doesn't fix a perfusion problem. Crushing the tablet is about formulation, and that's irrelevant when the drug itself is contraindicated. Here's a WGU D455 exam tip for you. Metformin plus poor perfusion equals lactic acidosis risk. Any condition that compromises blood flow, heart failure, sepsis, contrast dye procedures, means you hold the metformin. Quick recall hook. Metformin hates poor perfusion. Bad flow equals sign hold metformin. 14. A client being discharged on exenatide for type 2 diabetes management receives education about when to seek emergency medical attention. The nurse wants to ensure the client can recognise the most serious potential adverse effect of this medication class. Which symptom should the nurse emphasise as requiring immediate provider notification? A. Mild nausea after the first injection. B. Slight decrease in appetite initially. C. Occasional headache in the morning. D. Development of significant abdominal pain. Do you know the answer? Correct answer. D. Development of significant abdominal pain. Explanation. Option D is correct because abdominal pain in a client taking exenatide may indicate pancreatitis, a serious and potentially life-threatening adverse effect of GLP-1 receptor agonists requiring immediate medical evaluation and intervention. Option A is incorrect because mild nausea is a common and expected gastrointestinal side effect when starting exenatide therapy. It typically diminishes over time and does not indicate a dangerous complication requiring emergency attention. Option B is incorrect because a slight decrease in appetite is an expected pharmacological effect of GLP-1 receptor agonists and may actually support weight management goals. This does not represent a dangerous adverse reaction. Option C is incorrect because occasional headaches are a minor and common side effect that does not suggest pancreatitis or another life-threatening complication. This symptom would not typically warrant immediate emergency provider notification. A client going home on exenatide for type 2 diabetes, the nurse wants to make sure they know the one symptom that means get to a doctor immediately. The answer is development of significant abdominal pain. Exenatide is a GLP-1 receptor agonist, and the most serious adverse effect in this drug class is pancreatitis, inflammation of the pancreas. Abdominal pain, especially pain that radiates to the back, is the hallmark warning. Mild nausea after the first injection, totally normal. GLP-1 drugs slow gastric emptying, and nausea is the most common startup side effect. It usually fades. Decreased appetite. That's actually part of how the drug helps with weight management. It's a feature, not a bug. Morning headaches, minor and common, nothing that screams emergency. Here's a WGU D455 exam tip for you. GLP-1 receptor agonists and pancreatitis go together on exams. When you see exenatide or liraglutide, the dangerous adverse effect is always abdominal pain, suggesting pancreatitis. Quick recall hook. GLP-1 drugs =, guard the pancreas. Abdominal pain =, alarm. 15. A client with type 1 diabetes is found unresponsive in their hospital room, with no intravenous access currently established. The nurse checks the blood glucose level and confirms severe hypoglycemia. Based on the emergency protocol for this situation, which intervention should the nurse implement first? A. Administer glucagon intramuscularly as prescribed. B. Place oral glucose gel inside cheek. C. Attempt to start a peripheral intravenous line. D. Provide orange juice through a straw. Do you know the answer? Correct answer, A. Administer glucagon intramuscularly as prescribed. Explanation. Option A is correct because glucagon, given intramuscularly, raises blood glucose by stimulating hepatic glycogen breakdown. When intravenous access is unavailable and the client is unresponsive, intramuscular glucagon is the appropriate emergency intervention. Option B is incorrect because placing oral glucose gel in the mouth of an unresponsive client creates a significant aspiration risk. The client cannot protect their airway or swallow safely without consciousness and an intact gag reflex. Option C is incorrect because attempting to establish intravenous access delays the critical glucose correction. Intramuscular glucagon is immediately available and effective without requiring the time needed for venous access establishment. Option D is incorrect because giving orange juice to an unresponsive client is extremely dangerous due to aspiration risk. Oral intake of any liquid requires the client to be alert enough to swallow and protect their airway. Type 1 diabetic found unresponsive in their room. No IV access. Blood glucose confirms severe hypoglycemia. What now? Administer glucagon intramuscularly. Glucagon works by telling the liver to break down stored glycogen and release glucose into the bloodstream. It's the go-to emergency drug when IV access isn't available and the client can't swallow. Putting oral glucose gel in an unresponsive client's mouth is an aspiration risk. They can't swallow, they can't protect their airway. Same problem with orange juice through a straw. Pouring liquid into the mouth of someone who's unconscious is dangerous. Trying to start an IV line delays treatment. Every second matters with severe hypoglycemia, and glucagon IM works fast. You can work on IV access after the glucagon is on board. Here's a WGU D455 exam tip for you. Unresponsive plus hypoglycemia plus no IV access always equals glucagon Stammermann. M. The three conditions together point to one answer. Quick recall hook. No IV, no consciousness equals sign, glucagon goes in the muscle. 16. A nurse enters the room of a client admitted with heart failure exacerbation and notices a full pitcher of water on the bedside table. The client is also lying completely flat in bed. Knowing the pathophysiology of heart failure and standard nursing interventions, which observation should the nurse address first? A. Check if the client has eaten lunch. B. Do you know the answer? Verify the telemetry monitor connections. C. Remove the full water pitcher promptly. D. Request a physical therapy consultation. Correct answer, C. Remove the full water pitcher promptly. Explanation. Option C is correct because heart failure clients are typically on fluid restriction, and an unrestricted full water pitcher at the bedside undermines this critical therapeutic measure. Excess fluid intake worsens volume overload and pulmonary congestion. So? Option A is incorrect because checking meal consumption, while part of nutritional assessment, is not the most urgent concern when an unrestricted fluid source is immediately available to a fluid-restricted heart failure client. Option B is incorrect because verifying telemetry connections is a routine monitoring task. While cardiac monitoring is important, the immediate safety hazard of unrestricted fluid access in heart failure takes higher priority. Option D is incorrect because requesting a physical therapy consultation is appropriate for rehabilitation planning, but does not address the immediate clinical concern of a fluid-restricted client having unlimited water access at the bedside. Nurse walks into a heart failure client's room and sees two problems: a full water pitcher on the bedside table and the client lying flat. Which one gets addressed first? Remove the water pitcher. This might seem less dramatic than the positioning issue, but think about it. The pitcher represents an immediate, accessible threat. Heart failure clients are on fluid restriction because excess volume worsens pulmonary congestion and makes the heart work harder. A full pitcher of water sitting right there means the client could drink unrestricted amounts at any moment. The flat positioning is also a problem because lying supine increases venous return and worsens congestion. But the client is already in that position. It's a current state, not an escalating risk. The pitcher is an active hazard waiting to cause harm. Checking if the client ate lunch is routine. Verifying telemetry connections is standard monitoring. Neither is as urgent as removing the unrestricted fluid source. Here's a WGU D455 exam tip for you. In heart failure questions, fluid restriction violations are high-priority safety concerns. An available fluid source in a restricted client's room is a hazard to remove immediately. Quick recall hook: heart failure plus water pitcher equals sign remove it. Fluid restriction is sacred. 17. An overweight client with heart failure is preparing for discharge and asks the nurse which snacks would be appropriate to purchase from the grocery store. The nurse needs to recommend options that are consistent with a low-sodium, heart-healthy diet. Which combination of grocery items should the nurse suggest? A. Cheddar cheese cubes and canned fruit. B. Salted chips and diet frozen dinners. C. Canned soup and processed deli meat. D. Natural whole almonds and air-popped popcorn. Can you guess the answer? Correct answer: D. Natural whole almonds and air-popped popcorn. Explanation: option D is correct because unsalted natural almonds provide heart-healthy fats, while plain air-popped popcorn is a low-sodium, high-fibre snack. Both choices align with dietary goals for heart failure management. Yo. Option A is incorrect because cheddar cheese cubes are high in sodium and saturated fat, while canned fruit in heavy syrup contains unnecessary added sugar. Neither choice supports the heart-healthy, low-sodium dietary goals. Option B is incorrect because salted chips contain excessive sodium and processed frozen dinners are typically very high in sodium content. Both items directly contradict the low-sodium dietary restriction essential for heart failure. Option C is incorrect because canned soup and processed deli meat are among the highest sodium food sources commonly available. These items would significantly worsen fluid retention and cardiac workload in heart failure. An overweight heart failure client heading home wants snack ideas. The nurse needs options that are low sodium and heart healthy. The right picks are natural whole almonds and plain air-popped popcorn. Unsalted almonds give you healthy fats without the sodium bomb. Air-popped popcorn, no butter, no salt, is a high-fibre snack that's basically sodium-free. Now the wrong choices. Cheddar cheese cubes, loaded with sodium and saturated fat. Two things heart failure clients need to minimise. Canned fruit in heavy syrup adds unnecessary sugar without nutritional benefit. Salted chips are obviously high sodium. Diet frozen dinners sound healthy, but are packed with sodium as a preservative and flavour enhancer. Canned soup and deli meat are some of the worst sodium offenders in the grocery store. Here's a WGU D455 exam tip for you. On diet questions for heart failure, the correct answer is always the option with the lowest sodium. Fresh, unsalted, and unprocessed items win every time. Quick recall hook: heart failure diet equals sign, think fresh, think naked food. No cans, no processing, no added salt. 18. A client with type 2 diabetes is admitted with acute decompensated heart failure and severe shortness of breath. The nurse reviews the home medication list, which includes metformin and propranolol. Considering the client's current acute condition, which nursing action regarding these medications is most appropriate? A. Continue both medications as scheduled. B. Withhold both metformin and propranolol. C. Withhold only metformin and continue propranolol. D. Continue metformin and withhold only propranolol. Do you know the answer? Correct answer, B. Withhold both metformin and propranolol. Explanation. Option B is correct because metformin risks lactic acidosis when tissue perfusion is compromised, and propranolol can worsen acute decompensated heart failure by reducing cardiac contractility. Both medications should be withheld during acute exacerbation. Option A is incorrect because continuing both medications during acute decompensated heart failure creates two separate dangers. Metformin increases lactic acidosis risk, while propranolol further reduces the already compromised cardiac output. Option C is incorrect because while withholding metformin is correct, continuing propranolol during acute heart failure decompensation is dangerous. Beta blockers reduce cardiac contractility and can significantly worsen the acute clinical deterioration. Option D is incorrect because this approach addresses only the propranolol concern while ignoring the metformin danger. Continuing metformin during acute heart failure with compromised perfusion significantly increases the risk of fatal lactic acidosis. A type 2 diabetic on metformin and propranolol gets admitted with acute decompensated heart failure and severe dyspnea. Which meds do you hold? Both of them. Metformin we already covered. Lactic acidosis risk shoots up when perfusion drops, but propranolol is also a problem here. Propranolol is a beta blocker, and beta blockers reduce cardiac contractility. In stable chronic heart failure, certain beta blockers are actually beneficial. But during acute decompensation, when the heart is struggling to pump effectively, reducing contractility further is the last thing you want. It can push the client into cardiogenic shock. Continuing both is dangerous for two separate reasons. Withholding only metformin, but keeping propranolol still leaves the contractility problem. Keeping metformin but withholding only propranolol still leaves the lactic acidosis risk. You need to drop both. Here's a WGU D455 exam tip for you. When a question lists multiple home medications and the client's condition has changed acutely, evaluate each drug against the current clinical picture separately. If both are harmful in the new context, hold both. Quick recall hook. Acute heart failure =, hold metformin for perfusion, hold beta blockers for contractility. 19. A client arrives at the emergency department reporting chest pain and admits to taking sildenafil within the past several hours. The emergency physician considers available interventions for acute coronary syndrome. Which medication must the nurse recognise as absolutely contraindicated for this client? A. Nitroglycerin in any form. B. Aspirin by mouth immediately. C. Morphine for pain management. D. Heparin for anticoagulation therapy. What do you think is the answer? Correct answer, A. Nitroglycerin in any form. Explanation. Option A is correct, because the combination of phosphodiesterase 5 inhibitors, like sildenafil with any nitrate, causes severe, potentially fatal hypertension. This is an absolute contraindication that the nurse must recognise and communicate immediately. Option B is incorrect because aspirin is appropriate and commonly administered during acute coronary syndrome events. Aspirin inhibits platelet aggregation and is not contraindicated when the client has recently taken sildenafil medication. Option C is incorrect because morphine may be administered as part of acute coronary syndrome management for pain relief. Morphine does not interact dangerously with phosphodiesterase 5 inhibitors the way nitrates do. Option D is incorrect because heparin is a standard anticoagulation therapy used in acute coronary syndrome management. Heparin does not have a dangerous pharmacological interaction with phosphodiesterase 5 inhibitor medications. Client rolls into the ED with chest pain and admits to taking sildenafil within the past few hours. The emergency doc is thinking about treatment options. Which drug is absolutely off the table? Nitroglycerin. In any form, this is one of the most tested drug interactions in nursing. Sildenafil is a phosphodiesterase 5 inhibitor. Nitroglycerin is a nitrate. Both drugs cause vasodilation. Together they produce profound, potentially fatal hypertension. The blood pressure drops so far and so fast that the heart can't perfuse its own tissue. Aspirin is fine. It works on platelets and doesn't interact with sildenafil. Morphine is fine for pain management. Heparin is standard for acute coronary syndrome. None of those interact dangerously with PDE5 inhibitors. Only nitrates are the problem. Here's a WGU D455 exam tip for you. Sildenafil plus nitroglycerin is a classic exam question. Whenever you see sildenafil, tadalafil, or any erectile dysfunction drug in the stem, immediately look for a nitrate in the options and mark it as contraindicated. Quick recall hook. Sildenafil plus nitrates equal sign, severe drop. PDE5 and nitrates never mix. 20. A client with heart failure exacerbation is found lying completely flat in bed and reports increased difficulty breathing. The nurse understands that body positioning directly affects cardiac preload and pulmonary congestion in heart failure. Which positioning intervention should the nurse implement immediately to provide relief? A. Place the client in a prone position. B. Lower the head of bed completely flat. C. Elevate the head of bed upward. D. Position the client on the right side. Do you know the answer? Correct answer, C. Elevate the head of bed upward. Explanation. Option C is correct because elevating the head of bed reduces venous return to the heart and decreases pulmonary congestion. This position uses gravity to redistribute blood volume away from the lungs, improving breathing. Option A is incorrect because the prone position does not reduce pulmonary congestion effectively in heart failure. This position does not provide the gravitational benefit needed to decrease venous return and relieve dyspnea. Option B is incorrect because a completely flat position increases venous return to the heart and worsens pulmonary congestion. This is the opposite of the therapeutic positioning needed for a dyspneic heart failure client. Option D is incorrect because simply turning to the right side does not address the hemodynamic issue of increased venous return causing pulmonary congestion. Lateral positioning alone does not provide the same benefit as head elevation. Heart failure client found lying flat and reporting worsened breathing difficulty. What do you do about the positioning? Elevate the head of the bed. The physiology here is straightforward. When a heart failure client lies flat, gravity pulls blood from the extremities back toward the heart. That increases preload. The already weakened heart can't handle the extra volume, so fluid backs up into the lungs. That's orthopnea, difficulty breathing when lying flat. Raising the head of the bed uses gravity in reverse. Blood pools more in the lower extremities, less comes back to the heart. Pulmonary congestion eases, and the client breathes easier. Prone position doesn't help with venous return redistribution. Lowering the bed completely flat? That's what's causing the problem. It would make things worse. Right side lying? Lateral positioning doesn't address the fundamental hemodynamic issue. You need elevation, not rotation. Here's a WGU D455 exam tip for you. Heart failure plus dyspnea plus flat in bed is almost always answered by elevating the head of bed. The concept is reducing preload through gravity. Quick recall hook. Heart failure can't breathe, equal sign head of bed up. Gravity is your friend. 21. A client with Addison disease develops weakness, confusion, and dehydration following an acute viral illness. Laboratory values reveal sodium of 129, glucose of 54, and potassium of 5.3. The nurse should anticipate that the healthcare provider will prescribe which priority intervention. A. Oral potassium supplement immediately. B. Intravenous normal saline bolus only. C. Subcutaneous regular insulin injection. D. Intravenous hydrocortisone replacement. What do you think is the answer? Correct answer, D. Intravenous hydrocortisone replacement. Explanation: option D is correct because intravenous hydrocortisone replaces deficient cortisol in Addison disease adrenal crisis. This single intervention addresses the underlying hormonal deficiency and helps normalize the electrolyte imbalances and dangerously low glucose level. Option A is incorrect because potassium is already elevated in this client due to aldosterone deficiency. Administering additional potassium would worsen the hyperkalemia and increase the risk of potentially fatal cardiac dysrhythmias. Option B is incorrect because while intravenous fluid replacement helps with dehydration, normal saline alone does not address the critical cortisol deficiency driving all the metabolic abnormalities seen in adrenal crisis. Option C is incorrect because the low glucose level results from cortisol deficiency, not excessive insulin. Administering insulin would further lower the already dangerously low blood glucose and could cause a life-threatening hypoglycemic crisis. This question puts together Addison disease, a stress event, and a set of ugly lab values. The client has weakness, confusion, dehydration after a viral illness. Labs show sodium at 129, low. Glucose at 54, dangerously low. Potassium at 5.3, high. What ties all of this together? Cortisol deficiency. Addison disease means the adrenal cortex isn't producing enough cortisol or aldosterone. An acute illness is a physiological stressor that demands even more cortisol, and the body can't deliver. That's adrenal crisis. The priority intervention is intravenous hydrocortisone. This one drug addresses the root problem. It replaces the missing cortisol, which then helps normalize sodium, raise blood glucose, and bring potassium back down. Oral potassium? The potassium's already high at 5.3. Adding more could trigger a fatal cardiac arrhythmia. Normal saline alone handles dehydration, but doesn't fix the hormone deficit driving the whole crisis. Insulin? The glucose is 54. Already critically low. Insulin would crash it further and could kill the client. Here's a WGU D455 exam tip for you. When you see Addison disease plus low sodium, low glucose, and high potassium together, the answer is always IV hydrocortisone. That lab triad is your signal. Quick recall hook. Addison crisis =, add, cortisol. Hydrocortisone fixes all three labs. 22. A client admitted with syndrome of inappropriate antidiuretic hormone and a critically low sodium level shows signs of confusion and lethargy. The nurse understands that severe hyponatremia creates a dangerous neurological risk. Which intervention should the nurse implement first to protect the client from injury? A. Initiate seizure precautions immediately. B. Restrict all fluid intake starting now. C. Administer hypertonic saline solution rapidly. D. Encourage increased oral sodium intake. Do you know the answer? Correct answer, A. Initiate seizure precautions immediately. Explanation: option A is correct because severe hyponatremia below 120 significantly increases seizure risk due to cerebral edema. Initiating seizure precautions is the priority intervention to protect the client from injury. Option B is incorrect because while fluid restriction is an important treatment for CADHH, it addresses the underlying cause over time. The immediate priority is protecting the client from seizure-related injury before managing fluid balance. Option C is incorrect because administering hypertonic saline too rapidly can cause osmotic demyelination syndrome, a devastating neurological complication. While hypertonic saline may be indicated, the immediate safety priority is seizure prevention. Option D is incorrect because encouraging oral sodium intake is insufficient to correct critically low sodium levels in CADH. The severe hyponatremia requires medical interventions beyond dietary modification, and seizure safety comes first. SIAD, syndrome of inappropriate antidiuretic hormone. The body holds onto too much water, which dilutes the sodium. This client's sodium is critically low, and they're confused and lethargic. What's the first move? Initiate seizure precautions. When sodium drops below 120, the brain swells because water follows the osmotic gradient into brain cells. That cerebral edema makes seizures a real and immediate danger. Seizure precautions: padding the side rails, having suction at bedside, keeping the bed low. Protect the client from injury when a seizure hits. Fluid restriction treats the underlying CAIH, but it works over time, not instantly. Hypertonic saline can raise sodium, but if given too fast, it causes osmotic demyelination syndrome. You trade one brain injury for another. Encouraging oral sodium: way too slow and way too mild for a critically low level. Here's a WGU D455 exam tip for you. SIAD means dilutional hyponatremia. When sodium is critically low, think seizures first. Protect the client from injury before treating the cause. Quick recall hook: SIAD equal sign sodium is always too darn hypo. Low sodium equal sign seizure risk, equal sign precautions first. 23. Following a craniotomy, a client begins producing 600 milliliters of urine per hour with a specific gravity of 1.004 and reports extreme thirst. The nurse suspects a new endocrine complication based on these findings. Which laboratory test is most critical to monitor? A. Blood glucose level every 2 hours. B. Serum sodium level for hyponatremia. C. Liver function panel for hepatic injury. D. Serum potassium level for cardiac risk. Do you know the answer? Correct answer: B. Serum sodium level for hyponatremia. Explanation: Option B is correct because the massive dilute urine output in diabetes insipidus causes dangerous water loss, leading to hyponatremia. Monitoring serum sodium is critical because severely elevated levels can cause fatal neurological complications. Option A is incorrect because blood glucose is not the primary concern in diabetes insipidus. Despite the similar name, diabetes insipidus involves antidiuretic hormone dysfunction, rather than glucose metabolism disturbance seen in diabetes mellitus. Option C is incorrect because liver function testing is not relevant to diabetes insipidus. This condition results from insufficient antidiuretic hormone production or action following craniotomy and does not involve hepatic pathology. Option D is incorrect because while electrolyte monitoring is important overall, serum sodium is the most critical value in diabetes insipidus. The excessive water loss primarily drives dangerous hyponatremia rather than potassium imbalance. Post-craniotomy client starts putting out 600 milliliters of urine per hour. Specific gravity is 1.004. That's extremely dilute. And the client is incredibly thirsty. This screams diabetes insipidus. The surgery likely damaged the posterior pituitary or the hypothalamus, cutting off antidiuretic hormone production. Without ADH, the kidneys can't concentrate urine, so water just pours through. The most critical lab to monitor is serum sodium. All that water loss concentrates the sodium in the blood, driving it up toward hyponatremia. Severely elevated sodium causes neurological damage, confusion, seizures, coma. Blood glucose? Despite the word diabetes in the name, diabetes insipidus has nothing to do with glucose metabolism. Liver function? No hepatic involvement here at all. Potassium? It matters generally, but sodium is the electrolyte being directly and dangerously affected by the massive water loss. Here's a WGU D455 exam tip for you. Diabetes insipidus after brain surgery shows up as massive dilute urine output plus extreme thirst. The critical lab is always sodium. Watch for hyponatremia, quick recall hook, DI equal sign dry inside. Water leaves, sodium concentrates. 24. A client with severe hypothyroidism presents with life-threatening myxedema coma requiring emergency treatment. The healthcare provider orders thyroid hormone replacement therapy. The nurse anticipates that the medication will be administered through a specific route due to the pathophysiology of this condition. Which route should the nurse prepare? A. Oral tablet with a full glass of water. B. Subcutaneous injection in the abdomen. C. Rectal suppository for slow absorption. D. Intravenous infusion for rapid action. What do you think is the answer? Correct answer: D. Intravenous infusion for rapid action. Explanation: option D is correct because gastrointestinal absorption is severely impaired during myxedema coma due to decreased metabolic function. Intravenous levothyroxine sodium ensures rapid and reliable delivery when the critical condition demands immediate action. Option A is incorrect because oral administration is unreliable in myxedema coma. The severely impaired gastrointestinal motility and absorption that characterize this life-threatening condition would prevent adequate uptake of oral thyroid hormone. Option B is incorrect because subcutaneous injection does not provide the rapid onset of action needed in a myxedema coma emergency. The decreased peripheral circulation in a severe hypothyroidism further impairs subcutaneous medication absorption. Option C is incorrect because rectal suppository administration is not the standard route for emergency thyroid hormone replacement. This route does not guarantee the predictable, rapid absorption required to treat a life-threatening myxedema crisis. Myxedema coma, the worst-case scenario of hypothyroidism. Everything has slowed to a crawl. Metabolism is nearly shut down, the body temperature drops, heart rate drops, mental status tanks. This client needs thyroid hormone replacement, and they need it fast. The route has to be intravenous. The GI tract in myxedema coma is basically offline. Gut motility is so depressed that an oral tablet would just sit there unabsorbed. You can't wait for a drug that isn't getting into the bloodstream. IV levothyroxine bypasses the gut entirely and gets the hormone into circulation where it can start working. Subcutaneous injection, poor peripheral circulation in severe hypothyroidism means the drug won't absorb reliably from a sub-Q site either. Rectal suppository, not standard for thyroid replacement in emergencies, and absorption is unpredictable. Here's a WGU D455 exam tip for you. Myxedema coma means every system is sluggish, including the gut. When the GI tract can't absorb, the answer is always IV. Quick recall hook, myxedema equals sign, everything slow. Gut can't absorb, go IV. 25. A nurse is caring for a client with Cushing syndrome and needs to delegate appropriate tasks to the unlicensed assistive personnel on the unit. The nurse must determine which activities fall within the scope of practice for the UAP role. Which task is most appropriate to delegate? A. Assess the client for weakness patterns. B. Evaluate the client's sleep quality changes. C. Weigh the client and report any gain. D. Interpret the morning laboratory results. Do you know the answer? Correct answer: C. Weigh the client and report any gain. Explanation: option C is correct because weighing a client and reporting findings is a data collection task appropriate for unlicensed assistive personnel. The UAP can obtain the weight while the registered nurse interprets and acts on the results. Option A is incorrect because assessing for weakness patterns requires clinical judgment and interpretation of neuromuscular findings. Assessment is a registered nurse responsibility that cannot be delegated to unlicensed assistive personnel. Option B is incorrect because evaluating sleep quality changes involves clinical analysis and interpretation of the client's condition over time. Evaluation requires nursing judgment and falls outside the unlicensed assistive personnel scope of practice. Option D is incorrect because interpreting laboratory results requires advanced clinical knowledge and critical thinking to determine appropriate nursing actions. This analytical task must be performed by the registered nurse. Cushing syndrome client on the unit. The nurse needs to hand off some tasks to the UAP. Which one is appropriate? Weigh the client and report any gain. That's a data collection task. Take a number, report it back. No clinical judgment required. The RN then decides what the weight change means. Assessing for weakness patterns? That's assessment. The UAP doesn't assess. It requires interpreting neuromuscular findings and connecting them to the disease process. Evaluating sleep quality changes. That's evaluation. Another core nursing function. The UAP can report that a client didn't sleep, but analysing the pattern and its clinical significance is RN territory. Interpreting lab results? That's analysis requiring advanced clinical knowledge. No part of lab interpretation belongs to the UAP. Here's a WGU D455. Exam tip for you. Delegation questions follow a simple rule. UAPs collect data and report. They do not assess, evaluate, interpret, or teach. If the task requires judgment, it stays with the RN. Quick recall hook. UAP =, collect and report. RN =, assess and interpret. 26. A client's laboratory results reveal an ionized calcium level significantly above the normal range. The nurse understands that elevated calcium directly affects cardiac conduction and neuromuscular function. Before notifying the healthcare provider, which assessment finding should the nurse prioritize obtaining to evaluate the most life-threatening risk? A. Depth of tendon reflexes bilaterally. B. Skin turgor on the forearm. C. Apical pulse rate and rhythm. D. Colour and amount of urine output. Can you guess the answer? Correct answer. C. Apical pulse rate and rhythm. Explanation. Option C is correct because hypercalcemia shortens the QT interval and increases the risk of fatal cardiac dysrhythmias. Assessing apical pulse rate and rhythm identifies dangerous conduction changes requiring immediate emergency intervention. Option A is incorrect because while tendon reflexes may be diminished in hypercalcemia due to neuromuscular depression, this finding is not immediately life-threatening compared to the cardiac dysrhythmia risk that demands priority assessment. Option B is incorrect because skin turgor provides information about hydration status, but does not directly assess the most dangerous complication of hypercalcemia. Cardiac rhythm disturbances pose the greatest immediate threat to survival. Option D is incorrect because monitoring urine output is important for overall fluid balance assessment, but it does not identify the most life-threatening consequence of severe hypercalcemia, which involves dangerous cardiac conduction abnormalities. The client's ionized calcium is way above normal, severe hypercalcemia. Before calling the provider, which assessment should the nurse grab first? Apical pulse rate and rhythm. Here's the deal. Calcium directly affects the heart's electrical conduction system. High calcium shortens the QT interval on the ECG and makes the heart irritable. Fatal dysrhythmias can happen without warning. That's the most immediately lethal complication. Tendon reflexes might be diminished because hypercalcemia depresses neuromuscular function. But diminished reflexes won't kill the client in the next 5 minutes. Skin turgor tells you about hydration. Useful, but not the top threat. Urine output matters for fluid balance, but again, it's the cardiac rhythm that could stop the heart. Here's a WGU D455. Exam tip for you. High calcium means cardiac risk. When you see elevated calcium in a question, think heart first. Check the pulse rate and rhythm. Quick recall hook. High calcium =, heart trouble. Check the apical pulse. 27. A client reports new onset of numbness and tingling in the fingertips and around the mouth. The nurse recalls that these sensory changes are classic early indicators of a specific electrolyte disturbance. Which laboratory value should the nurse review first to confirm the suspected imbalance? A. Serum calcium level. B. Serum potassium level. C. Blood urea nitrogen value. D. Serum magnesium level. What do you think is the answer? Correct answer A. Serum calcium level. Explanation: option A is correct because numbness and tingling in fingers and perioral area are hallmark signs of hypercalcemia. These symptoms relate to increased neuromuscular excitability caused by low calcium, often confirmed by positive Chvostek and Trousseau signs. Option B is incorrect because potassium imbalances typically present with muscle weakness, cardiac rhythm changes, and cramping, rather than the characteristic perioral and fingertip tingling pattern that specifically indicates low calcium levels. Option C is incorrect because blood urea nitrogen reflects kidney function and waste product clearance. Elevated BUN does not produce the specific neuromuscular irritability pattern of perioral and fingertip numbness seen in hypercalcemia. Option D is incorrect because while low magnesium can contribute to calcium imbalances, the classic presentation of perioral numbness and fingertip tingling points directly to calcium as the primary electrolyte to evaluate first. Client comes in reporting numbness and tingling in the fingertips and around the mouth. These are textbook hypocalcemia symptoms. The perioral tingling and fingertip numbness happen because low calcium makes nerves hyperexcitable. They fire too easily. This is also where Chvostek sign and Trousseau sign come from. Tap the facial nerve and the face twitches. That's Chvostek. Inflate a blood pressure cuff and the hand spasms. That's Trousseau. Both confirm neuromuscular irritability from low calcium, so the nurse should review the serum calcium level first. Potassium imbalances show up differently. Think muscle weakness, cardiac rhythm changes, and cramping rather than that specific tingling pattern. BUN reflects kidney function and waste products, not neuromuscular excitability. Magnesium can contribute to calcium problems, but the presentation points directly at calcium as the primary culprit. Here's a WGU D455 exam tip for you. Perioral numbness plus fingertip tingling is the classic hypercalcemia pair. When you see that combination, calcium is your answer. Quick recall hook. Tingling tips and lips equal sign think calcium. Chvostek and Trousseau seal the deal. 28. A client with end-stage renal disease who missed scheduled dialysis presents with fatigue, muscle cramps, tingling in the extremities, and tachycardia. The ECG reveals peaked T waves. The nurse recognizes the urgency of the situation. Which combination of interventions should the nurse anticipate to address both the cardiac risk and the underlying electrolyte excess? A. Oral potassium supplement and fluid bolus. B. Magnesium sulfate and sodium bicarbonate. C. Vitamin D supplement and loop diuretic. D. Insulin with dextrose and calcium gluconate. What do you think is the answer? Correct answer: D. Insulin with dextrose and calcium gluconate. Explanation: option D is correct because insulin with dextrose temporarily shifts potassium into cells, lowering dangerous serum levels. Calcium gluconate stabilizes the cardiac membrane against dysrhythmia, while definitive treatment through hemodialysis is arranged. Option A is incorrect because administering additional potassium to a client who already has life-threatening hyperkalemia would further elevate the dangerously high levels and significantly increase the risk of fatal cardiac arrest. Option B is incorrect because while sodium bicarbonate may help shift potassium intracellularly, magnesium sulfate does not address hyperkalemia. This combination misses the critical cardiac membrane stabilization provided by calcium gluconate. Option C is incorrect because vitamin D supplementation addresses calcium absorption over time and does not treat acute hyperkalemia. A loop diuretic may promote some potassium excretion but cannot address the immediate cardiac danger. End-stage renal disease client missed dialysis, fatigue, muscle cramps, tingling, tachycardia, and the ECG shows peak T waves. That's hyperkalemia staring you in the face. Peak T waves mean the potassium is already affecting the heart's electrical system. Two things need to happen simultaneously: protect the heart and lower the potassium. Calcium gluconate stabilizes the cardiac membrane so the heart doesn't go into a fatal arrhythmia. It doesn't lower potassium. It buys you time. Insulin with dextrose 50% actually shifts potassium from the blood back into cells. Insulin drives potassium intracellularly, and the dextrose prevents the insulin from crashing the blood sugar. Together, these two interventions bridge the gap until dialysis can remove the excess potassium permanently. Giving more potassium? Absolutely lethal. Magnesium sulfate doesn't treat hyperkalemia. Vitamin D works over weeks for calcium absorption, completely useless in an emergency. Here's a WGU D455 exam tip for you. Peaked T waves plus missed dialysis equals hyperkalemia. The intervention pair to memorize is calcium gluconate to protect the heart, plus insulin and dextrose to shift potassium into cells. Quick recall hook. Peaked T's equal sign potassium emergency. Calcium guards the heart. Insulin moves the K. 29. An older client with diabetes has been taking furosemide daily as prescribed. The nurse is planning care and considering the most important assessment to perform before administering today's dose. Understanding the primary electrolyte risk associated with loop diuretics. Which action should the nurse complete first? A. Measure the client's daily body weight. B. Review the daily serum electrolyte results. C. Check the most recent blood glucose level. D. Assess bilateral lower extremity edema. Do you know the answer? Correct answer, B. Review the daily serum electrolyte results. Explanation. Option B is correct because furosemide is a loop diuretic that causes significant potassium wasting. Reviewing serum electrolytes before administration identifies hyperkalemia, which can cause dangerous cardiac dysrhythmias, especially in clients with diabetes. Option A is incorrect because while daily weight monitoring helps evaluate fluid balance and diuretic effectiveness, it does not identify the critical electrolyte depletion risk that must be assessed before administering another dose. Option C is incorrect because checking blood glucose is important for diabetic management, but does not address the primary safety concern of potassium depletion caused by loop diuretics, which poses an immediate cardiac risk. Option D is incorrect because assessing edema evaluates the therapeutic response to the diuretic, but does not identify dangerous potassium depletion. Electrolyte status must be confirmed before the medication risk can be evaluated. Older diabetic client on daily furosemide. Before giving today's dose, what should the nurse do first? Review the daily serum electrolyte results. Furosemide is a loop diuretic. It works in the loop of Henle and it's aggressive. It pulls out sodium, chloride and potassium along with the water. The big danger is potassium wasting. Low potassium causes cardiac dysrhythmias, and that risk is amplified in a diabetic client who may already have cardiac complications lurking. You need to know the potassium level before you give another dose that's going to pull more out. Daily weight. Good for tracking fluid status and whether the diuretic is working, but it doesn't tell you if the electrolytes are safe enough for another dose. Blood glucose? Important for the diabetes, but it's not the primary safety concern with furosemide. Edema assessment. Again, that tracks the drug's effectiveness, not its safety. Here's a WGU D455 exam tip for you. Before giving any loop diuretic, check potassium. Furosemide wastes potassium, and hyperkalemia causes fatal arrhythmias. Quick recall hook. Furosemide equal sign flushes potassium. Check K before you give it. 30. A nurse reviews laboratory findings revealing a critically low serum sodium level alongside an elevated total calcium level. Potassium and chloride are within normal range. The nurse must decide which assessments to prioritise based on the most dangerous complications of these specific imbalances. Which combination represents the most important findings to evaluate? A. Mental status and muscle strength. B. Skin colour and capillary refill time. C. Bowel sounds and appetite level. D. Pupil response and visual acuity. Can you guess the answer? Correct answer. A. Mental status and muscle strength. Explanation. Option A is correct because critically, low sodium causes cerebral edema leading to confusion and seizures, while hypercalcemia causes neuromuscular depression and weakness. Together, these assessments capture the most dangerous complications of both imbalances. Option B is incorrect because skin colour and capillary refill primarily reflect circulatory and perfusion status rather than the neurological and neuromuscular complications most directly caused by severe hyponatremia and hypercalcemia. Option C is incorrect because bowel sounds and appetite, while potentially affected by electrolyte imbalances, do not address the most immediately dangerous complications. Seizure risk from hyponatremia and cardiac risk from hypercalcemia take priority. Option D is incorrect because pupil response and visual acuity are neurological assessments primarily associated with intracranial pathology rather than the specific cerebral edema pattern caused by severe hyponatremia and neuromuscular effects of hypercalcemia. Lab results show sodium at 120, critically low, and total calcium at 12.5, elevated. Potassium and chloride are fine, two imbalances happening at once, so the nurse needs to pick assessments that cover the most dangerous complications of both. The answer is mental status and muscle strength. Low sodium causes cerebral edema. Water shifts into brain cells, swelling them. That produces confusion, lethargy, and seizures. Mental status assessment catches those neurological changes. High calcium depresses neuromuscular function. Muscles get weak. Reflexes diminish, and at the extreme, respiratory muscles can fail. Muscle strength assessment captures that. Skin colour and capillary refill. Those reflect circulatory status, not the specific dangers of these two electrolyte problems. Bowel sounds and appetite. They can be affected, but they're not where the lethal complications show up. Pupil response and visual acuity. Those point more toward intracranial pathology from structural causes, not the cerebral edema pattern of hyponatremia. Here's a WGU D455 exam tip for you. When a question gives you two simultaneous electrolyte imbalances, match each imbalance to its most dangerous complication and pick the assessments that cover both. Quick recall hook. Low sodium attacks the brain, high calcium attacks the muscles. Check both. 31. A client presents with intermittent abdominal cramping, nausea, vomiting, no bowel movement for 4 days, and high-pitched bowel sounds heard in the upper quadrants. The client also has a surgical history of abdominal hernia repair. The nurse suspects a specific gastrointestinal emergency. Which finding most strongly differentiates this condition from acute cholecystitis? A. Reports of nausea and vomiting episodes. B. Moderate tenderness across the abdomen. C. Elevated white blood cell count on labs. D. High-pitched bowel sounds with obstipation. What do you think is the answer? Correct answer, D. High-pitched bowel sounds with obstipation. Explanation. Option D is correct because high-pitched hyperactive bowel sounds above the obstruction combined with obstipation are findings specific to bowel obstruction. Cholecystitis presents with different bowel patterns and pain related to fatty meals. Option A is incorrect because nausea and vomiting are non-specific gastrointestinal symptoms that occur in both bowel obstruction and acute cholecystitis. This finding alone cannot differentiate between the two conditions on examination. Option B is incorrect because abdominal tenderness is a general finding present in many gastrointestinal conditions, including both bowel obstruction and cholecystitis. It does not provide the specific distinction needed for differential assessment. Option C is incorrect because an elevated white blood cell count indicates an inflammatory or infectious process, but occurs in many abdominal conditions. It does not differentiate between bowel obstruction and acute cholecystitis specifically. Client with cramping, nausea, vomiting. No bowel movement for 4 days, high-pitched bowel sounds in the upper quadrants, and a history of abdominal surgery. The nurse suspects bowel obstruction. The question asks what differentiates this from cholecystitis. The answer is high-pitched bowel sounds with obstipation. Here's why that combination is specific. In bowel obstruction, the intestine above the blockage goes into overdrive trying to push contents through. That's the hyperperistalsis producing those high-pitched tinkling sounds. Below the blockage, everything is quiet and nothing is passing. That's the obstipation, meaning complete absence of stool and gas. Cholecystitis doesn't produce that pattern. Cholecystitis pain relates to fatty meals, and you might see jaundice, but the bowel sounds are typically normal. Nausea and vomiting occur in both conditions. Abdominal tenderness is non-specific. An elevated WBC shows inflammation, but doesn't point to one diagnosis over the other. Here's a WGU D455. Exam tip for you: high-pitched bowel sounds plus obstipation is the bowel obstruction signature. When a question asks you to differentiate, look for the finding that only appears in one condition. Quick recall hook. Obstruction equal sign. Overactive above, silent below. High-pitched sounds plus no stool. Equal sign obstruction. 32. A client with a confirmed small bowel obstruction has a nasogastric tube placed for decompression and is positioned in semi-Fowler position. The nurse is reviewing the plan of care for additional appropriate interventions. The client asks if they can have some ice chips to relieve dry mouth. Which response by the nurse is most appropriate? A. Provide a small cup of crushed ice. B. Allow ice chips in limited amounts. C. Explain that oral intake is not permitted. D. Offer warm broth as a substitute. Can you guess the answer? Correct answer, C. Explain that oral intake is not permitted. Explanation. Option C is correct because clients with bowel obstruction must remain NPO to prevent further distension and vomiting. Even small amounts of oral intake, including ice chips, can worsen the obstruction and increase aspiration risk. Option A is incorrect because providing crushed ice constitutes oral intake and is contraindicated in bowel obstruction. Any ingested fluid adds to the gastric contents that the nasogastric tube is working to decompress and remove. Option B is incorrect because allowing limited ice chips still introduces fluid into the gastrointestinal tract. In bowel obstruction, even minimal oral intake stimulates secretions and contributes to distension the treatment aims to resolve. Option D is incorrect because warm broth is an oral fluid that is equally contraindicated in bowel obstruction. The NPO status means nothing by mouth, regardless of the temperature, consistency or volume of the substance. Bowel obstruction client with an NG tube in place, semi-Fowler position, and they ask for ice chips because their mouth is dry. The answer is to explain that oral intake is not permitted. NPO means nothing by mouth, not even ice chips. This trips people up because ice chips seem so harmless. But here's the problem. Ice melts into water. That water goes into the stomach. The stomach is already full of backed up contents that the NG tube is actively trying to decompress. Adding any fluid, even a tiny amount, works against the decompression. It can worsen distension, stimulate more secretions, and increase aspiration risk. Crushed ice? Still oral intake. Limited ice chips? Still adding fluid to a system that can't move it forward. Warm broth? Just a warmer version of the same problem. NPO is NPO. The nurse can offer mouth swabs or lip moisturiser for comfort, but nothing goes in the mouth that gets swallowed. Here's a WGU D455 exam tip for you. With bowel obstruction, NPO is absolute. Any question offering ice chips, limited sips, or any oral option is wrong. Quick recall hook. Bowel obstruction equal sign. Nothing by mouth. Ice chips melt into problems. 33. A client with a history of daily alcohol use presents with severe left upper quadrant pain, nausea, and vomiting. The healthcare provider diagnoses acute pancreatitis. The nurse understands that the pancreas needs complete rest for recovery. Which principles should guide the primary management approach for this client's nutritional status? A. withhold food and fluids to rest pancreas. B. Provide a high-protein liquid diet immediately. C. Start total parenteral nutrition right away. D. Offer small, frequent, low-fat, solid meals. Do you know the answer? Correct answer, A. Withhold food and fluids to rest pancreas. Explanation. Option A is correct because withholding food and fluid intake is the priority in acute pancreatitis management. Oral intake stimulates pancreatic enzyme production and secretion, which worsens the autodigestive inflammatory process, attacking pancreatic tissue. Option B is incorrect because providing any oral diet, including liquids, stimulates the pancreas to produce digestive enzymes. During acute inflammation, this enzyme stimulation worsens the autodigestive process and intensifies tissue damage. Option C is incorrect because total parenteral nutrition may be considered later for prolonged cases, but the immediate priority management principle is pancreatic rest through NPO status rather than initiating complex nutritional support immediately. Option D is incorrect because solid food intake, even in small frequent amounts, strongly stimulates pancreatic enzyme secretion. Low-fat meals reduce stimulation compared to high-fat, but any oral intake is contraindicated during a acute pancreatitis. Acute pancreatitis from a history of daily alcohol use, severe left upper quadrant pain, nausea, vomiting. The management principle the nurse needs to understand is to withhold food and fluids to rest the pancreas. The pancreas is essentially digesting itself. Pancreatic enzymes have activated inside the organ instead of in the duodenum. Any food or fluid that enters the GI tract triggers the pancreas to produce more enzymes, which pours gasoline on the fire. NPO status stops that stimulation cycle. A high-protein liquid diet? Oral intake of any kind stimulates enzyme production. That's the opposite of rest. Total parenteral nutrition right away? TPN might be needed later if the client can't eat for a prolonged period, but the immediate principle is pancreatic rest through NPO, not jumping straight to complex nutritional support. Small low-fat meals? Less stimulating than high-fat meals, sure, but still stimulating. Any oral intake is contraindicated during the acute phase. Here's a WGU D455 exam tip for you. Acute pancreatitis management starts with NPO. The pancreas needs rest, and oral intake, regardless of type, triggers enzyme production. Quick recall hook. Pancreatitis =, pancreas, digesting itself. Stop feeding it, NPO. 34. A nurse is providing dietary education to a client with active Crohn's disease who needs to maintain adequate nutrition while minimizing gastrointestinal symptom aggravation. The client asks which foods would be safest during a disease flare. Which food combination best meets the high-calorie, high-protein, low-residue dietary requirements? A. Raisins and fresh orange juice daily. B. Raw vegetable salad with whole grains. C. Popcorn and dried fruit. Trail mix. D. Cheese and buttermilk as protein sources. Do you know the answer? Correct answer, D. Cheese and buttermilk as protein sources. Explanation. Option D is correct because cheese provides high-quality protein in a low-residue form, and buttermilk offers easily digestible protein with beneficial probiotics. Both choices meet the nutritional goals without adding irritating fibre during active disease. Option A is incorrect because raisins are dried fruits high in insoluble fibre that can exacerbate Crohn's symptoms. Orange juice is acidic and can irritate the already inflamed gastrointestinal tract, worsening pain and diarrhea. Option B is incorrect because raw vegetables and whole grains are high fibre, high residue foods contraindicated during active Crohn's disease. These foods increase bowel motility and can worsen cramping, diarrhea, and abdominal pain significantly. Option C is incorrect because popcorn is a high fibre food and dried fruits contain concentrated insoluble fiber. Both significantly increase residue in the gastrointestinal tract, directly opposing the low residue dietary goal for active Crohn's disease. Active Crohn's disease flare. The client needs calories and protein but can't tolerate fiber. The dietary goal is high calorie, high protein, low residue. The right choice is cheese and buttermilk. Cheese delivers concentrated protein in a low residue form. It doesn't leave much bulk in the intestines. Buttermilk provides easily digestible protein plus probiotics that may support gut health. Neither one adds irritating fiber. Raisins and orange juice. Raisins are dried fruit packed with insoluble fiber, exactly what inflamed intestines can't handle. Orange juice is acidic and irritates the already raw GI lining. Raw vegetables and whole grains? Both are high fiber, high residue foods. During an active flare, they increase bowel motility and worsen cramping, diarrhea, and pain. Popcorn and dried fruit trail mix. Popcorn is high fiber, dried fruit is concentrated insoluble fiber. That combination would be terrible for an inflamed gut. Here's a WGU D455. Exam tip for you. Crohn's disease during a flare means low fiber and low residue. Anything dried, raw, or whole grain is wrong. Soft, bland, easily digestible protein sources are right. Quick recall hook. Crohn flare equal sign, calm the gut. Soft protein in, rough fiber out. 35. A client recently diagnosed with gastroesophageal reflux disease asks the nurse to explain how antacids work to relieve symptoms. The nurse wants to provide an accurate explanation that distinguishes antacid action from other reflux medications. Which response by the nurse best describes the mechanism of antacids? A. They coat the esophageal lining protectively. B. They neutralize the acid in the stomach. C. They decrease gastric acid production directly. D. They speed up gastric emptying time. What do you think is the answer? Correct answer, B. They neutralize the acid in the stomach. Explanation. Option B is correct because antacids work by chemically neutralizing hydrochloric acid already present in the stomach. This raises the gastric pH and provides rapid but temporary symptom relief from the burning discomfort of reflux. Option A is incorrect because coating the esophageal lining describes the mechanism of sucralfate, which forms a protective barrier over damaged mucosa. Antacids work by neutralizing acid rather than providing a physical protective coating. Option C is incorrect because decreasing gastric acid production describes the mechanism of proton pump inhibitors and histamine 2 receptor blockers. Antacids neutralize existing acid, but do not reduce or prevent new acid secretion. Option D is incorrect because speeding gastric emptying describes the mechanism of prokinetic agents like metoclopramide. Antacids do not affect gastric motility or the rate at which stomach contents move into the small intestine. 30. GERD client asks how antacids work. The answer is straightforward. Antacids neutralize the acid already sitting in the stomach. They're basic compounds that chemically react with hydrochloric acid, raising the gastric pH. Relief is fast but temporary because the stomach keeps making new acid. Students get tripped up because they confuse antacid mechanisms with other reflux drugs. Coating the esophageal lining, that's sucralfate. It forms a paste-like barrier over damaged tissue, decreasing gastric acid production. That's what proton pump inhibitors and H2 blockers do. They turn down the acid-making machinery, speeding up gastric emptying. That's metoclopramide, a prokinetic agent that gets food moving out of the stomach faster. Each of these 4 drug classes treats GERD differently. Antacids are the simplest. They just neutralize what's already there. Here's a WGU D455. Exam tip for you. Know the 4 GERD drug mechanisms cold. Antacids neutralize, PPIs and H2 blockers reduce production. Sucralfate coats. Prokinetics speed emptying. Questions love to mix these up. Quick recall hook. Antacids equal sign acid neutralizers. They don't coat, don't block, don't speed up. they neutralize. 36. A young client arrives at the emergency department after falling from a significant height. The trauma team is assembling, and the nurse must begin the primary survey using the ABCDE approach. Two actions must happen simultaneously as the very first interventions. Which pair of actions correctly reflects this simultaneous first priority? A. Check blood pressure and insert an IV. B. Obtain a detailed medical history first. C. Stabilize the spine and open airway. D. Draw blood specimens and start oxygen. Can you guess the answer? Correct answer, C. Stabilize the spine and open airway. Explanation: option C is correct because in trauma, cervical spine stabilization and airway management are simultaneous first priorities. Spinal cord injury must be prevented while ensuring the client can breathe, as both are immediately life-threatening concerns. Option A is incorrect because blood pressure assessment and IV insertion are circulation interventions that come after airway and breathing are secured in the ABCD primary survey sequence. These are important, but not the first simultaneous actions. Option B is incorrect because obtaining a detailed medical history is part of the secondary survey using the ample mnemonic. The primary survey focuses on immediately life-threatening conditions before gathering comprehensive background information. Option D is incorrect because drawing blood and starting oxygen are appropriate interventions, but are not the simultaneous first actions. Airway patency and spinal protection must be established before moving to breathing support and laboratory assessment. Young client falls from a significant height. Trauma team assembles. The nurse starts the primary survey using ABCDE. What two things happen simultaneously as the absolute first actions? Stabilize the cervical spine and open the airway. In trauma, you always assume spinal injury until imaging proves otherwise. A fall from height is a classic mechanism for cervical fracture, but you also can't let the client die from an obstructed airway while you're protecting the spine. So both happen at the same time. One person stabilizes the C-spine with manual inline stabilization, while another opens the airway using a jaw thrust maneuver, which doesn't flex the neck. Blood pressure and IV? Those come later under C for circulation. Medical history? That's secondary survey territory. The ample mnemonic happens after the primary survey stabilizes the client. Drawing blood and starting oxygen? Those are appropriate but follow airway and spine protection. Here's a WGU D455. Exam tip for you. Trauma primary survey always starts with simultaneous C-spine stabilization and airway management. Nothing else comes first. Quick recall hook. Trauma first equal signs spine and airway at the same time. Protect the cord, open the pipe. 37. A client presents with sudden right-sided arm and leg weakness, facial droop, and difficulty speaking. The nurse recognizes these as signs of an acute stroke affecting the left cerebral hemisphere. After obtaining vital signs and while awaiting the CT scan, which positioning intervention should the nurse implement? A. Position the client completely flat in bed. B. Turn the client onto the right side. C. Place the client in a prone position. D. Elevate the head of bed to 30 degrees. Do you know the answer? Correct answer, D. Elevate the head of bed to 30 degrees. Explanation: option D is correct because elevating the head of bed to 30 degrees with head and neck in neutral alignment promotes venous drainage from the brain and helps reduce intracranial pressure during the acute stroke phase. Option A is incorrect because lying completely flat increases intracranial pressure by impeding venous drainage from the brain. In acute stroke, this positioning can worsen cerebral edema and extend the neurological damage already occurring. Option B is incorrect because turning onto the affected right side does not address the critical need for intracranial pressure management. The priority is head elevation for venous drainage rather than lateral positioning during the acute phase. Option C is incorrect because the prone position is not appropriate for acute stroke management. This position does not promote cerebral venous drainage and makes neurological assessment and airway management extremely difficult for the nursing team. Client with sudden right-sided weakness, facial droop, difficulty speaking. Classic left hemisphere stroke. Vital signs obtained, Connecticut scan ordered. While waiting, how should the nurse position the client? Elevate the head of bed to 30 degrees with head and neck in neutral alignment. 30 degrees is the sweet spot. It promotes venous drainage from the brain through the jugular veins, which helps reduce intracranial pressure. Keeping the head and neck neutral, no twisting, no flexing, prevents kinking of those veins. Lying completely flat impedes venous drainage and increases intracranial pressure, which worsens cerebral edema and extends the stroke damage. Turning onto the right side, the affected side, doesn't address the intracranial pressure issue. The priority is elevation, not lateral positioning. Prone position makes neurological assessment nearly impossible and doesn't help with venous drainage. Here's a WGU D455 exam tip for you. Acute stroke positioning is always head of bed at 30 degrees with neutral alignment. The number 30 and the word neutral should jump out at you in the answer choices. Quick recall hook. Stroke equal sign 30 degrees, neutral neck. Drain the veins, save the brain. 38. A nurse enters the room of a client with a possible stroke who has facial paralysis and left-sided immobility. A family member is attempting to give the client water through a straw. The nurse understands the serious risk this poses to the client. Which action must the nurse take immediately? A. Stop the feeding and assess swallowing. B. Allow small sips and monitor for coughing. C. Replace the straw with a thickened liquid. D. Ask the family to continue more slowly. Do you know the answer? Correct answer. A. Stop the feeding and assess swallowing. Explanation. Option A is correct because stroke clients with facial paralysis are at extremely high risk for aspiration. The nurse must immediately stop all oral intake and formally assess the swallowing reflex before any food or fluid is permitted. Option B is incorrect because allowing even small sips of water in a client with unassessed swallowing function after stroke creates immediate aspiration risk. Liquid is the most easily aspirated consistency when the swallow reflex is impaired. Option C is incorrect because replacing the straw with thickened liquid still introduces oral intake before swallowing function has been assessed. No dietary modification is safe until a formal swallowing evaluation confirms the client can protect the airway. Option D is incorrect because asking the family to continue giving water more slowly does not reduce the aspiration risk. The speed of fluid administration is irrelevant when the client's ability to safely swallow has not yet been evaluated. Stroke client with facial paralysis and left-sided immobility. A family member is trying to give water through a straw. The nurse walks in and has to act immediately. Stop the feeding and assess the swallowing reflex. Full stop. Stroke clients with facial paralysis are at extreme aspiration risk. The muscles that control swallowing may be paralyzed or weakened along with the facial muscles. Water, thin liquid, is actually the hardest consistency to swallow safely when the mechanism is impaired because it moves fast and can slip into the airway before the client can react. Allowing small sips and monitoring for coughing is not safe. By the time you hear a cough, fluid may already be in the lungs, and some stroke clients aspirate silently without coughing at all. Replacing the straw with thickened liquid sounds reasonable, but you still haven't assessed whether the client can swallow anything safely. Telling the family to continue more slowly changes nothing. Speed doesn't matter if the swallow reflex is absent. Here's a WGU D455 exam tip for you. Stroke plus facial paralysis plus someone trying to give oral intake equals stop everything and assess swallowing first. No exceptions. Quick recall hook. Stroke and swallowing equal sign. Assess before anything enters the mouth. 39. An adolescent client with a known seizure history begins having a grand mal seizure immediately after being admitted to the unit. the nurse is at the bedside and must respond appropriately during the active seizure event. Which nursing action is most appropriate during the seizure? A. Place a padded tongue blade between teeth. B. Observe and document the seizure carefully. C. Physically restrain the client's movements. D. Immediately call a rapid response team. What do you think is the answer? Correct. Answer. B. Observe and document the seizure carefully. Explanation. Option B is correct because during an active seizure, the nurse should carefully observe and document the onset, duration, type of movements, and level of consciousness. This information guides medical management and helps evaluate the seizure disorder. Option A is incorrect because placing any object between the teeth during an active seizure is contraindicated. This outdated practice can break teeth, cause oral injury, or obstruct the airway, creating additional harm to the seizing client. Option C is incorrect because physically restraining a client during a seizure increases the risk of musculoskeletal injury, including fractures and joint dislocations. The nurse should protect from environmental hazards without restricting movements. Option D is incorrect because calling a rapid response team is premature for a client with a known seizure history unless the seizure becomes prolonged or the client fails to recover afterwards. Observation is the appropriate initial response. Adolescent with a known seizure disorder starts having a grand mal seizure right after admission. The nurse is at the bedside. What's the correct action during the active seizure? Observe and document carefully. During an active seizure, the nurse's job is to be a witness with a clock. Note the time it started, what the movements look like. Tonic, clonic, one-sided versus bilateral. The level of consciousness, eye movements, incontinence, anything visible. This information is gold for the neurologist managing the seizure disorder. Do not place anything between the teeth. That old padded tongue blade advice is outdated and dangerous. You can break teeth, injure the mouth, or create an airway obstruction. The tongue cannot be swallowed during a seizure. Do not physically restrain the client. Holding down a seizing person increases the risk of fractures and dislocations. Clear the area of hazards, cushion the head, but don't fight the movements. Calling a rapid response team. For a client with a known seizure history, this is premature unless the seizure goes beyond 5 minutes or the client doesn't recover. Here's a WGU D455 exam tip for you. During an active seizure, the nurse observes, times and documents. Nothing goes in the mouth and nobody restrains. Quick recall hook. Seizure equal sign. Watch the clock. Protect the space. Hands off the mouth. 40. 1 week after an above-the-knee amputation, a client reports feeling numbness in the foot that was removed. The client appears anxious and asks whether something is wrong. The nurse understands this neurological phenomenon and its expected occurrence after amputation. Which response by the nurse is most therapeutic? A. Notify the surgeon of a complication. B. Administer additional pain medication now. C. Educate about normal phantom limb sensation. D. Reassure that the feeling will stop tomorrow. Do you know the answer? Correct answer, C. Educate about normal phantom limb sensation. Explanation. Option C is correct because phantom limb sensation is a normal neurological phenomenon where the brain continues receiving signals from severed nerve pathways. Education and reassurance about this expected occurrence help reduce the client's anxiety. Option A is incorrect because phantom limb sensation is an expected occurrence after amputation, not a surgical complication. Notifying the surgeon is unnecessary and may increase the client's anxiety by implying something abnormal has happened. Option B is incorrect because phantom limb sensation is a neurological phenomenon rather than an acute pain event requiring analgesic intervention. The appropriate response is education about the expected nature of these sensory experiences. Option D is incorrect because telling the client the sensation will stop tomorrow provides false reassurance. Phantom limb sensation may persist for an extended period or indefinitely, and honest education is more therapeutic than inaccurate promises. 1 week after an above-the-knee amputation, the client says the foot that was removed feels numb. They're anxious and worried something is wrong. The right response is to educate about phantom limb sensation. This is a normal neurological phenomenon. When a limb is amputated, the nerve pathways that used to carry signals from that limb don't just shut off. The brain's sensory map still has that limb represented, and the severed nerves can still generate signals. The brain interprets those signals as coming from a foot that no longer exists. It's not a complication, it's not a sign of surgical error. It's expected, and the client needs to know that. Notifying the surgeon implies something went wrong. It didn't, and that call would unnecessarily alarm the client. More pain medication treats this as a pain problem, when it's actually a sensory, educational issue. Reassuring that it will stop tomorrow gives false information. Phantom sensations can persist for months, years, or permanently. Honest education is the therapeutic response. Here's a WGU D455 exam tip for you. Phantom limb sensation. After amputation is always normal and expected. The correct answer is always education and reassurance, never treatment escalation or false promises. Quick recall hook. Missing limb, present sensation, equal sign phantom. Educate, don't escalate. 41. A client recently survived a natural disaster and reports intrusive memories, sleep disturbance, and sensitivity to loud environmental sounds since being transferred from the intensive care unit. The nurse recognizes a pattern of psychological symptoms following traumatic exposure. Which therapeutic approach is most appropriate as an initial intervention? A. Prescribe lithium for mood stabilization. B. Begin phototherapy sessions each morning. C. Schedule electroconvulsive therapy sessions soon. D. Initiate cognitive behavioral therapy referral. Can you guess the answer? Correct. Answer D. Initiate cognitive behavioral therapy referral. Explanation. Option D is correct because cognitive behavioral therapy addresses maladaptive thought patterns and coping mechanisms in acute stress disorder. It helps the client process traumatic memories and develop healthier responses to trauma-related triggers. Option A is incorrect because lithium is a mood stabilizer used primarily for bipolar disorder management. It does not address the intrusive memories, hyperarousal, and trauma-related symptoms characteristic of acute stress disorder following disaster exposure. Option B is incorrect because phototherapy involves timed light exposure used to treat seasonal affective disorder by regulating circadian rhythms. It has no therapeutic role in treating the trauma-related symptoms of acute stress disorder. Option C is incorrect because electroconvulsive therapy is reserved for treatment-resistant psychiatric conditions such as severe refractory depression. It is not a first-line or appropriate initial intervention for acute stress disorder. A disaster survivor reports intrusive memories, sleep disturbance, and sensitivity to loud sounds after being moved out of the ICU. The nurse sees a clear pattern: acute stress disorder from traumatic exposure. What's the best initial therapeutic approach? Initiate a cognitive behavioral therapy referral. CBT is the gold standard first-line treatment for acute stress disorder. It works by helping the client identify and restructure the maladaptive thought patterns that formed during the trauma. The client learns to process those intrusive memories in a controlled therapeutic setting and develop healthier coping responses to triggers like loud noises. Lithium, that's a mood stabilizer for bipolar disorder. It does nothing for trauma-related intrusive memories or hyperarousal. Lithium manages manic and depressive episodes through a completely different mechanism. Phototherapy, that's timed light exposure for seasonal affective disorder. It regulates circadian rhythms when reduced daylight disrupts mood. It has zero application to trauma processing. Electroconvulsive therapy, ECT is a last resort reserved for treatment-resistant conditions like severe refractory depression, when nothing else has worked. You don't jump to ECT for acute stress disorder. That's like bringing a bulldozer to plant a flower. Here's a WGU D455 exam tip for you. Acute stress disorder and PTSD questions almost always point to CBT as the initial therapeutic intervention. Medications may supplement, but therapy comes first. Quick recall hook. Trauma thoughts need therapy. CBT fixes the thinking. Lithium, lights, and electricity are for other problems. 42. A manic client who was threatening others received haloperidol, 5 mg intramuscularly, and was placed in seclusion after de-escalation attempts failed. The nurse assigned to monitor the client must prioritize a specific safety assessment related to the recently administered medication. Which assessment takes highest priority? A. Observe for extrapyramidal symptoms closely. B. Monitor hourly blood glucose readings. C. Assess for signs of allergic skin reaction. D. Check bilateral peripheral pulse quality. Do you know the answer? Correct answer: A. Observe for extrapyramidal symptoms closely. Explanation. Option A is correct because haloperidol can cause acute dystonic reactions within minutes to hours of administration, including laryngospasm that can compromise the airway. Immediate detection allows rapid treatment with diphenhydramine or benztropine. Option B is incorrect because while antipsychotics may affect metabolic parameters over time, hourly blood glucose monitoring is not the priority assessment immediately after haloperidol administration. The acute extrapyramidal side effect risk demands attention first. Option C is incorrect because while allergic reactions are possible with any medication, the most likely and immediately dangerous adverse effect of haloperidol is an acute dystonic reaction. Extrapyramidal symptoms pose a greater airway threat than typical skin allergies. Option D is incorrect because checking peripheral pulses is a circulatory assessment unrelated to the most dangerous immediate adverse effects of haloperidol. The priority concern after antipsychotic administration is the risk of acute dystonia, compromising the airway. Manic client got haloperidol 5 mg IM and was placed in seclusion after de-escalation failed. Now the nurse is monitoring. What's the highest priority assessment? Observe for extrapyramidal symptoms. Haloperidol is a typical antipsychotic, first generation, and these drugs are notorious for extrapyramidal side effects. The most dangerous one in the acute period is dystonia. Acute dystonic reactions can hit within minutes to hours of administration. The muscles contract involuntarily. The neck can twist, the jaw can lock, and the most terrifying one is laryngospasm, where the muscles of the larynx clamp down and the airway closes. A client in seclusion who develops laryngospasm and isn't being watched could die. That's why this assessment trumps everything else. The treatment for acute dystonia is diphenhydramine or benztropine. Both are anticholinergic drugs that counteract the dopamine blockade causing the muscle spasm. Hourly blood glucose. Antipsychotics can affect metabolic parameters over time, but that's a long-term concern, not an immediate post-dose emergency. Allergic skin reaction? Possible with any drug, but not the most likely or most dangerous haloperidol-specific effect. Peripheral pulses? That's a circulatory check completely unrelated to antipsychotic side effects. Here's a WGU D455 exam tip for you. Haloperidol plus any question about post-administration monitoring equals extrapyramidal symptoms. The airway-threatening dystonic reaction is what you're watching for. Quick recall hook. Haldol =sign hunt for dystonia. Airway can close, watch for EPS. 43. A client with obsessive-compulsive disorder is observed repeatedly washing a table on the unit for the third consecutive time. The nurse understands that compulsive behaviours serve an anxiety-reducing function for the client. Which nursing approach best balances therapeutic support with gradual behaviour modification? A. Firmly interrupt the behaviour immediately. B. Restrict the client to the bedroom only. C. Allow the behaviour then redirect afterward. D. Explain that the table is already clean. What do you think is the answer? Correct answer, C. Allow the behaviour then redirect afterward. Explanation. Option C is correct because interrupting compulsive rituals abruptly increases the client's anxiety significantly. The therapeutic approach allows completion of the ritual and then gently redirects the client toward other meaningful activities. Option A is incorrect because firmly interrupting compulsive behaviour escalates anxiety dramatically in clients with obsessive-compulsive disorder. The sudden disruption removes the anxiety reduction mechanism without providing an alternative coping strategy for the client. Option B is incorrect because restricting the client to the bedroom isolates them from therapeutic interactions and environmental stimulation. Isolation worsens psychiatric symptoms and does not address the underlying anxiety driving the compulsive behaviour. Option D is incorrect because providing logical explanations about cleanliness does not address the anxiety driving the compulsive behaviour. Clients with OCD understand the irrationality, but cannot stop because the behaviour serves a psychological function. A client with OCD is washing a table for the third time in a row. The nurse knows compulsive behaviours serve a purpose. They reduce the overwhelming anxiety the client feels. So what's the therapeutic approach? Allow the behaviour to finish, then redirect to other activities. The compulsive ritual is the client's anxiety release valve. If you yank that valve away mid-cycle by firmly interrupting, anxiety skyrockets. The client doesn't feel better, they feel worse, and they'll likely restart the ritual or escalate to a different behaviour. The therapeutic strategy is patience followed by gentle redirection. Let them finish, then guide them towards something else, a walk, a group activity, a conversation. Over time, with treatment, the rituals decrease. Restricting the client to the bedroom, isolation worsens psychiatric symptoms across the board. You're removing environmental stimulation and therapeutic interaction without addressing the anxiety at all. Explaining the table is already clean. Logic doesn't work here. Clients with OCD usually know the behaviour is irrational. The problem isn't understanding, it's that the anxiety driving the behaviour overpowers rational thought. Telling them the table is clean is like telling someone with a phobia to just stop being afraid. Here's a WGU D455 exam tip for you. OCD rituals on the exam are always answered with allow the behaviour, then redirect. Never interrupt, never isolate, never use logic to argue against the compulsion. Quick recall hook. OCD ritual equals sign, let it finish, then redirect. Don't fight the anxiety valve. 44. A nurse is preparing to interview a client who may have experienced sexual abuse. The nurse understands that the approach to questioning significantly affects the likelihood of the client feeling safe enough to disclose. Which interview strategy is most appropriate to begin the assessment? A. Ask directly about the abuse incident. B. Begin with less sensitive questions first. C. Share personal values about the situation. D. Use vague, open-ended questions throughout. Do you know the answer? Correct answer, B. Begin with less sensitive questions first. Explanation. Option B is correct because building rapport and trust through less threatening questions before addressing the most difficult topics increases the likelihood of honest disclosure. A gradual approach respects the client's emotional safety and autonomy. Option A is incorrect because leading with the most difficult and sensitive questions about abuse causes defensive shutdown. The client needs to establish trust with the nurse before feeling safe enough to discuss traumatic experiences. Option C is incorrect because sharing personal values about abuse situations violates professional boundaries and can inadvertently influence the client's disclosure. The nurse must remain objective and create a non-judgmental therapeutic environment for assessment. Option D is incorrect because vague, open-ended questions throughout the interview are ineffective for gathering the specific information needed for abuse assessment. While open questions have value, the overall approach must move purposefully from general to specific. The nurse is about to interview a client who may have experienced sexual abuse. How should the questioning begin? Start with less sensitive questions first. Abuse disclosure is built on trust, and trust takes time. If the nurse walks in and immediately asks about the abuse, the client's defenses go up. Defensive shutdown means the client stops talking, minimizes what happened, or denies everything. Starting with low-threat questions, general health, daily routine, how they're feeling today, MA, builds rapport. The client starts to feel safe. The nurse demonstrates a non-judgmental presence. Then gradually the conversation can move toward the more difficult topics. The client is more likely to disclose honestly because trust has been established. Asking directly about the incident first, that's the shutdown trigger. Leading with the hardest question before any relationship exists puts the client on the defensive immediately. Sharing personal values about the situation, that violates professional boundaries. The nurse's personal opinions can influence the client's willingness to share and compromise the objectivity of the assessment. Vague, open-ended questions throughout. They sound therapeutic, but vagueness doesn't extract the specific information needed for a proper abuse assessment. The approach needs to be purposeful, general to specific, not vague throughout. Here's a WGU D455 exam tip for you. Abuse assessment interviews always start gentle and build toward the sensitive material. The answer is always begin with less threatening questions to build rapport. Quick recall hook. Abuse interview =, build trust first. Easy questions open the door. Hard questions come later. 45. A nurse discovers a client who has attempted suicide by cutting both wrists. Blood is visible and the client is on the floor of the bathroom. Multiple interventions are needed simultaneously, but the nurse must determine the very first priority action. Which action should the nurse perform first upon discovering this client? A. Apply direct pressure to both wrists. B. Immediately call the rapid response team. C. Estimate the total amount of blood loss. D. Check the client's level of consciousness. Can you guess the answer? Correct answer. D. Check the client's level of consciousness. Explanation. Option D is correct because assessing the level of consciousness immediately determines the severity of blood loss and hemodynamic compromise. This information guides the urgency and sequence of all subsequent interventions, including hemorrhage control and emergency activation. Option A is incorrect because while applying pressure to stop bleeding is critical, assessing consciousness first takes only seconds and provides essential information about the client's hemodynamic status that guides the entire emergency response sequence. Option B is incorrect because activating the rapid response team is important, but the nurse needs initial assessment data to communicate effectively. Checking consciousness first provides the critical information the team needs upon arrival. Option C is incorrect because estimating blood loss is a secondary assessment that takes more time than checking consciousness. The level of awareness provides faster and more reliable immediate information about the client's hemodynamic stability. The nurse finds a client on the bathroom floor with both wrists cut and visible blood. Multiple things need to happen fast, but what's the very first action? Check the client's level of consciousness. This takes seconds and tells you everything about how bad the situation is right now. A conscious client who's talking to you has a different level of urgency than an unconscious client who isn't responding. Consciousness reflects hemodynamic status, how much blood has been lost and how well the body is compensating. That single data point guides every subsequent decision: how aggressively to control bleeding, whether to call a code versus a rapid response, what to communicate to the arriving team. Applying direct pressure? Absolutely critical, but it comes second. You need that consciousness check first because it takes only a moment and changes the entire response plan. Calling the rapid response team? Yes, but with what information? Checking consciousness first gives you the data to make that call meaningful. Estimating blood loss? That's a secondary assessment that takes more time and provides less immediate clinical information than a quick consciousness check. Here's a WGU D455 exam tip for you. When you discover a patient in crisis, the first action is almost always a rapid assessment. Check consciousness, check responsiveness. It takes seconds and drives everything that follows. Quick recall hook. Find a crisis equal sign. Assess first, act second. Consciousness tells you the severity. 46. The charge nurse is making client assignments for the practical nurse, assisting the registered nurse on the medical surgical unit. 4 clients are available for assignment. Considering scope of practice and complexity of care, which client is most appropriate for the practical nurse to manage with RN oversight? A. Adult Shono, 1 day after laparoscopic cholecystectomy. B. Client scheduled for below-knee amputation. C. Client with alcoholism and hepatic failure. D. Client requiring new ostomy care education. What do you think is the answer? Correct answer, A. Adult, 1 day after laparoscopic cholecystectomy. Explanation. Option A is correct because a client 1 day after laparoscopic cholecystectomy is typically stable and predictable, requiring routine post-surgical monitoring and care well within the practical nurse's scope with RN oversight. Option B is incorrect because a client scheduled for amputation requires complex preoperative assessment, psychological support, and detailed surgical preparation. These needs involve the higher-level clinical judgment best provided by the registered nurse. Option C is incorrect because a client with alcoholism and hepatic complications presents a complex and potentially unstable clinical picture, requiring ongoing advanced assessment and rapid intervention skills of the registered nurse. Option D is incorrect because new ostomy care education involves complex teaching, psychosocial support, and assessment of client readiness and comprehension. Initial ostomy education requires the registered nurse's clinical judgment and teaching expertise. The charge nurse is assigning clients to the practical nurse. 4 options. Post-laparoscopic cholecystectomy on day 1, a client scheduled for amputation, a client with alcoholism and hepatic failure, and a client needing new ostomy education. Which one goes to the LPN? The post-lap chol client, day 1. This is a textbook stable, predictable patient. Laparoscopic cholecystectomy is a minimally invasive surgery. By day 1, the client is typically tolerating a diet, ambulating, managing pain with oral medications, and heading toward discharge. The LPN can handle the routine post-surgical monitoring, vitals, incision checks, medication administration, with RN oversight. The amputation client? Complex preoperative needs including psychological support, detailed surgical preparation, and teaching about post-op expectations. That requires RN-level assessment and planning. Alcoholism with hepatic failure. Unstable and unpredictable. Liver failure means coagulation problems, potential encephalopathy, electrolyte chaos, and risk of GI bleeding. The RN needs to be on top of that. New ostomy care education? Initial teaching requires the RN's clinical judgment to assess readiness, comprehension, and psychological adjustment. Education is an RN responsibility. Here's a WGU D455 exam tip for you. In delegation questions, the LPN gets the most stable and predictable client. Look for the patient who is post-procedure, recovering as expected, and needs routine care. Quick recall hook. LPN gets the boring patient. Stable, predictable, routine. Complex stays with the RN. 47. A client who received an open reduction internal fixation of the right femur is now experiencing sudden, increasing confusion and agitation. The nurse must contact the healthcare provider using S-bar communication format. When organising the clinical information, which element represents the assessment component of the S-bar report? A. The client fell at home last week. B. current medications and dosages listed? C. The client has increasing confusion now. D. The healthcare power of attorney contact. Do you know the answer? Correct answer, C. The client has increasing confusion now. Explanation. Option C is correct, because increasing confusion represents the nurse's clinical assessment of the acute change in the client's condition. In SBAR format, the assessment component communicates the nurse's professional interpretation of what is happening clinically. Option A is incorrect because the fall at home represents the background component of SBAR communication. Background provides relevant history and context that helps the healthcare provider understand how the current situation developed. Option B is incorrect because current medications and dosages represent the situation component, providing the factual, clinical context for the communication. This information sets the stage rather than conveying the nurse's clinical interpretation. Option D is incorrect because the healthcare power of attorney contact information is not a clinical assessment finding. This administrative detail is not relevant to the urgent SBAR communication about the client's acute change in condition. Post-ORIF of the right femur, the client suddenly becomes confused and agitated. The nurse needs to call the provider using SBAR. The question asks which piece of information is the assessment component. The answer is the increasing confusion. SBAR stands for situation, background, assessment, and recommendation. Each letter has a specific role. Situation describes what's happening right now in factual terms, the client's current medications and clinical context. Background gives the history, why the client is here, what happened before. For this client, the fall at home last week is the background. Assessment is where the nurse interprets the data. This is the clinical judgment piece. The nurse is saying something is acutely wrong and that something is increasing confusion. It's not just reporting a fact. It's the nurse's professional interpretation of the clinical picture. Recommendation is what the nurse thinks should happen next. The healthcare power of attorney contact? That's administrative information. It doesn't fit into any clinical component of SBAR. Here's a WGU D455 exam tip for you. The assessment in SBAR is always the nurse's clinical interpretation of the change. It answers the question, what do you think is happening? Look for the option that shows the nurse's judgment, not just a fact. Quick recall hook. SBAR assessment equals sign the nurse's clinical opinion. What's happening? Not what happened before. 48. A healthcare provider prescribes a placebo instead of actual pain medication for a client reporting significant discomfort. The nurse has concerns about this approach based on professional ethics and the duty to advocate for client welfare. Which action by the nurse best demonstrates appropriate ethical nursing practice? A. Administer the placebo without question. B. Tell the client about the placebo immediately. C. Refuse to administer and document refusal. D. Discuss ethical concerns with the provider. Do you know the answer? Correct answer, D. Discuss ethical concerns with the provider. Explanation? Option D is correct because the ANA Code of Ethics requires nurses to advocate for clients. Discussing placebo concerns with the provider addresses informed consent and beneficence, while maintaining a professional, collaborative relationship for resolving the issue. Option A is incorrect because administering a placebo without questioning the ethical implications fails the nurse's advocacy responsibility. The ANA Code of Ethics requires nurses to address concerns about treatments that may violate client rights. Option B is incorrect because immediately informing the client about the placebo without first discussing concerns with the provider undermines the therapeutic relationship and bypasses the appropriate professional communication chain for resolving concerns. Option C is incorrect because outright refusal without first discussing the concern with the provider is premature. Professional ethics require collaborative communication to resolve disagreements before taking unilateral action regarding prescribed treatments. A provider prescribes a placebo instead of actual pain medication for a client in significant discomfort. The nurse has ethical concerns. What's the right move? Discuss the ethical concerns with the provider. The ANA Code of Ethics is clear. Nurses advocate for their clients. Placebo use for pain management raises red flags around informed consent and the duty of beneficence. The client believes they're receiving pain relief. They're not. That's deceptive, and deception undermines the therapeutic relationship. But the nurse doesn't go rogue. The first step is professional dialogue with the prescriber. Maybe there's clinical reasoning the nurse isn't aware of. Maybe the provider will reconsider. The collaborative conversation is the ethical starting point. Administering without question? That makes the nurse complicit in potential ethical violation. The Code of Ethics doesn't allow blind compliance when client rights may be at stake. Telling the client immediately? That bypasses the chain of communication and could damage multiple relationships. Nurse-provider and provider-client, without first attempting to resolve the issue professionally. Refusing outright and documenting. That's jumping to the nuclear option before trying dialogue. Professional ethics demand collaborative resolution before unilateral action. Here's a WGU D455 exam tip for you. Ethical dilemma questions almost always have the answer of communicate with the provider first. Advocate, but through proper channels. Quick recall hook. Ethics problem equals sign talk to the provider. Advocate through dialogue, not defiance. 49. A nurse witnesses a preoperative client signing the surgical consent form. The client appears alert and oriented and has asked appropriate questions about the procedure. The nurse must understand exactly what the nursing signature on this document legally validates. Which statement best describes the legal meaning of the nurse's signature? A. The client understands risks and consented voluntarily. B. The surgeon explained all surgical alternatives. C. The nurse personally explained the procedure. D. The hospital accepts liability for complications. Do you know the answer? Correct answer. A. The client understands risks and consented voluntarily. Explanation. Option A is correct because the nurse's signature legally validates that the client understands the risks and benefits, is competent to sign without impaired judgment, and voluntarily grants permission for the procedure without coercion. Option B is incorrect because confirming that the surgeon explained alternatives is the surgeon's responsibility as part of obtaining informed consent. The nurse's witness signature does not validate the completeness of the physician's disclosure process. Option C is incorrect because explaining the surgical procedure to the client is the responsibility of the surgeon performing the operation. The nurse witnesses the signing but does not assume responsibility for providing the procedural explanation. Option D is incorrect because the consent form and the nurse's signature do not establish hospital liability for surgical complications. The document records the client's informed voluntary agreement to undergo the procedure after understanding the associated risks. The nurse witnesses a preoperative client sign the surgical consent form. The client is alert, oriented, and asked good questions. What does the nurse's signature on this form legally mean? It validates that the client understands the risks and benefits, is competent to sign without impaired judgment, and voluntarily gave permission. 3 components packed into one signature: understanding, competence, and voluntariness. The nurse isn't confirming that the surgeon did a thorough job explaining alternatives. That's the surgeon's responsibility during the informed consent conversation. The nurse wasn't necessarily present for that entire discussion, and the witness role doesn't extend to auditing the provider's disclosure. The nurse personally explained the procedure? No. Procedure explanation belongs to the operating surgeon. The nurse can clarify and reinforce, but the consent conversation is a physician responsibility. The hospital accepts liability for complications. Consent forms don't create liability assignments. they document the client's informed voluntary agreement. Signing doesn't mean the hospital guarantees a complication-free outcome. Here's a WGU D455 exam tip for you. The nurse's witness signature on consent means 3 things. The client understands, is competent, and consents voluntarily. Everything else in the options belongs to someone other than the nurse. Quick recall hook. Nurse witnesses consent equals sign. Understands competent, voluntary. 3 words, 1 signature. 50. A nurse who is removed from clinical duties after substance use has successfully completed a mandatory counselling programme and requests to return to practice. The charge nurse must determine the most appropriate and balanced approach that supports recovery while ensuring continued patient safety. Which decision best addresses both concerns? A. Permanently reassign to non-clinical duties. B. Allow return with medication administration monitoring. C. Require an additional year of counselling first. D. Deny the request until a new licence obtained. Do you know the answer? Correct answer, B. Allow return with medication administration monitoring. Explanation. Option B is correct because allowing return with enhanced medication oversight supports the nurse's recovery while maintaining patient safety. Peer assistance programs recognise substance use disorder as treatable and provide structured monitoring for returning practitioners. Option A is incorrect because permanent reassignment to non-clinical duties disregards the nurse's successful completion of mandatory treatment. This punitive approach conflicts with the peer assistance model that supports rehabilitation and return to practice. Option C is incorrect because requiring additional counselling beyond what the mandatory programme required creates an arbitrary barrier without clinical justification. The nurse has already met the established requirements for return to practice eligibility. Option D is incorrect because denying return until a new licence is obtained imposes a requirement that does not exist in standard return to practice protocols. Successful completion of mandatory counselling fulfills the established requirements for monitored re-entry to clinical duties. A nurse who was pulled from clinical duty for substance use has completed mandatory counselling and wants to come back to work. The charge nurse needs to find the approach that balances recovery, support with patient safety. The answer is to allow return with medication administration monitoring. This is the peer assistance model in action. Substance use disorder is recognised as a treatable medical condition, not a permanent character flaw. The nurse met the requirements of the mandatory programme. Denying re-entry after successful completion sends a punitive message that contradicts everything the profession says about recovery and rehabilitation. But patient safety can't be ignored either. Enhanced monitoring, specifically around medication access and administration provides the safeguard. Someone watches the nurse handle controlled substances. Counts are verified. The structure supports accountability without humiliation. Permanently reassigning to non-clinical duties. That's punishment disguised as a solution. It ignores the successful treatment and essentially ends the nursing career despite meeting all return requirements. Requiring another year of counselling? That's an arbitrary barrier with no clinical basis. If the mandatory programme set the standard and the nurse met it, adding more time is punitive, not therapeutic. Denying until a new licence is obtained? That requirement doesn't exist in standard peer assistance protocols. It creates a fictitious hurdle. Here's a WGU D455 exam tip for you. Impaired nurse questions always lean toward the recovery, supportive answer with safety monitoring built in. The profession treats substance use disorder. It doesn't permanently punish it. Quick recall hook. Impaired nurse completed treatment. Equal sign, return with monitoring. Support recovery, protect patients.
You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.